So what we're going to do is we're going to do a live discussion on each topic. Let's say, I'll give an example. On September 1st, imagine that we're going to do anatomy, okay? So we are going to do anatomy from morning around 8:39 to evening 6:37 in 2 sessions. The morning will be the live discussion of all the questions of these high-heeled, hot competency areas of INI-CET going in depth. And then we'll stop it by evening, around 2 more hours left as a second session, where we'll take all the images alone in asked in the last 5 years in INI-CET and the entire subject together and discuss the images alone to give you a focus on image-based questions and the applications around these topics. So it will be 2 parts in the bootcamp. One is the hardcore competency review of the entire subject, connecting you to each and every topic, and then a second smaller session of discussing all the images of the particular subject. Understood? So that is what is done on the day 1, and then you'll get 2 days to study. Like after first day anatomy, 2 days to revise or 1 day to revise anatomy by yourself from your primary notes, so that you can make sure that you get the 130 base correct. Understood? If not, studying this high yield area alone will never get you INI-CET. You have to make your fundamentals and basics strong and revise everything up. It's very, very important. Understood? So you do that 1 day revision and then you write the anatomy exam on the second day evening in the Medico app. And the next day, let's say if it is dermatology, 1 day dermatology, same thing. Morning the competency review topic question discussion, evening the image-based question discussion. Next day, time for you to study by yourself, evening exam. Then it's 2 days medicine. 2 days we'll discuss all the systems like this. Morning we will discuss the competency review topics. After that, evening image discussions. 2 to 3 days holiday, and third day evening exam. So that you are having a revision track to come back to your original notes, understand these are the areas to study, focus and learn more or go deeper. Also review a quick review of all the images and topics in the subject and making sure you touch your base notes completely, so that you're going to improve from week on week. So how do we assess that? Every week there will be an INI-CET mock test happening in Medico app, which you can come in and take, so that you will understand your score is improving or not.
Hello and welcome to the images part of this discussion. So in the images part, actually, see, in the morning session, I discussed the first three, the latest question papers. So whatever images were relevant to those question papers, I've discussed in that session itself. Tomorrow, I'll be discussing three more question papers, and the relevant images have been covered in that session itself. So now in the images part, I've tried to cover the images which I feel are important and which have actually been asked in the previous exams, and these are all images taken from Bailey and Love. So I will try to cover as many images as possible, and these are all standard images. These are all taken from Bailey and Love. I have not referred to any other book. Maybe a few images here and there I've taken online, but most of the images are from Bailey and Love. So I'm emphasizing this more and more because I feel that this is, it has a high potential of being asked in the exam. So the way I will be discussing these images is I won't be going into detail. So I will just tell you how to identify that image, and if there are any important points which I feel are important, which can be mentioned, I'll be saying that, but I will not be going into the topic in detail. So let us continue. Let us begin rather. So this image, it shows you a patient with multiple keloid scars. So now you have to learn to differentiate between a keloid scar and a hypertrophic scar. So now the main difference is hypertrophic scar, this is the lower image, it is within the incision line. So wherever the incision line is, it does not outgrow that, right? But with keloid scars, what happens is, see, there will be no scar or no wound which will be in this shape, right? So keloid scar is a scar which grows outside the boundaries of the incision. Now what you can see over here is this is a measure. So this instrument here, this is a measure, and it is used to mesh a split thickness skin graft, right? So the person over here, he is introducing the mesh, and here they are pulling the mesh out, and as it is being pulled out, you can see these meshes being formed, the holes, the small holes being formed. The advantage of this is it prevents seroma formation, prevents hematoma formation, it increases the surface area as well. So this is the measure. How do you identify the measure? This instrument here, see this person, he is pressing onto that. See, he's applying pressure and it comes out. Okay, so now this is a kind of wound dressing which is called a vac dressing or a vacuum assisted closure, right? It is also known as negative pressure wound therapy. It is also known as negative pressure wound therapy. And how you identify this is, so when I zoom in, you can see that there is some wound present over here, right? And you can see this black structure over there, that is the foam. So what happens is the foam absorbs all the exudates from the wound, and superficial to the foam is you have this uh, thing over here which keeps the foam in place, and this is connected to a suction. So whatever exudates are formed can easily be suctioned out. Now this is a degloving injury. This is a degloving buttock injury. So what do you mean by degloving injury? Degloving injury is an injury where the skin and subcutaneous fat are, it's like removing a glove basically. So what happens is the skin and the subcutaneous tissues, they are separated from its underlying deeper structures. So here you can see a degloving injury of the, this is the ring finger, this is the little finger. Okay, what surgical procedure is being done over here? The surgical procedure that is done over here is a fasciotomy, right? So how do you identify it as a fasciotomy? First is via the incision. So you can see a longitudinal incision. You can see a longitudinal incision, and this thing that you can see popping out, this is the muscle. This is the healthy muscle which is bulging. So once the healthy muscle is seen bulging, that means the procedure is being done correctly. Okay, so this is an image of necrotizing fasciitis of the anterior abdominal wall. So you can see a Foley's catheter over here. This is the right lower limb. This is the left lower limb. This is the, don't know whether it is a male or a female, but this is the perineum area. And this that you can see over here, this is the necrotic patch. It is, supposing if you rupture it, you will get something called a dishwater fluid. The fluid that will come out is called a dishwater fluid, right? Then You can see erythema, redness or inflammation all around it. Fine. All this is the erythema redness. Now this is necrotizing fasciitis of the anterior abdominal wall. Necrotizing fasciitis of the anterior abdominal wall is also called Melanese gangrene. Supposing there is necrotizing fasciitis of the scrotum, that is called Fournier's gangrene. So this is a pressure ulcer. How do you identify it to be a pressure ulcer? So firstly, by its location. Pressure ulcer is present on the sacral prominence, on the heel, on the occiput, on the greater trochanterus, wherever the patient is, wherever there is contact with pressure for a long time, right? Now this is a dirt ingrained scar. So this patient, see, this is the scar. This entire thing is the scar, right? But it looks black in size. It looks black in color. Why is that? That is because whenever the patient would have had a wound, the wound would not have been cleaned properly. So that dirt, it has become ingrained, it has become part of the scar itself, right? It is like the patient has got a tattoo. This white dot that you see over here, this white dot, this is a miliary lesion. It is a miliary lesion. Okay. Now this is a midline neck contracture. This is a midline neck contracture. And from a whatever the cause is, that cause is not so important, but it is a midline neck contracture. So you can see where the patient would have had some injury, and the wound has healed in such a way. So you can see a scar of a primary intention over here, and the wound has healed such a way that it is pulling the chin below. So this patient, to in order to relieve his problems, this contracture needs to be released. Okay. Now the procedure that is being shown in this image, this is called a multiple Z plasty. So you can see over here, if you look closely, you can see this is Z shaped, right? This is also Z shaped. So this Z shaped incision, it is performed in order to release a scar or in order to refashion something else, right? So this is a multiple Z plasty which releases the finger contracture. Okay, so now what is this? So now in this patient, you can see this is the midline wound, right? You can see that the wound below this, so you can see sutures over here, but here the wound is left open. It may have undergone dissection on its own, or the sutures may have removed. But what is important here is that you can see a surgical site infection over here. You can see a surgical site infection. Now, along with the surgical site infection being present, if you look closely, you can see, yeah, this looks kind of darkish brown, black, right? And there's fluid present over here. So this is actually feces. These are feces, and what is actually formed is a fecal fistula, right? So fecal fistula has formed. So there is some communication between the underlying bowel and the wound. Yeah. Now this over here is a stoma. Judging by its location, it is in the right lower quadrant, so it should be an ileostomy. Colostomy is usually present in the left lower quadrant. One more difference is, how do you notice an ileostomy? So when you look at this stoma, it seems to be protruding out, right? It is pouting out. It is pouting out. So an ileostomy pouts, whereas a colostomy is flush. Let me write it over here. Colostomy is flush. So what do you mean by this flush? So flush basically means that it is at the same level. So now supposing, say, this is the anterior abdominal wall and this is the stoma, it is at that level. It is not protruding out, whereas a ileostomy is protruding out. That is the difference. So here is another patient who has got, so see, you can see different scars over here. This is the umbilicus. This depression that you can see over here, that is the umbilicus. This incision is in the right upper quadrant. And this is a midline laparotomy wound. You can see there's some separation of wound over here. You can see that the wound is separated over here as well. But this looks healthy, right? This looks healthy. So basically in this patient, there is healing going on, and it is taking time. If you look more closely, you can see some lines over. These are sutures. All right. And what this part, if I were to take a guess, it would either be the subcutaneous fat or the fascia. Okay. So now what are these that you see, these various openings that you see over here? So these are drains. These are drains which the surgeon would have put for after the procedure was over. Okay. Now in this image, you can see redness, right? And you can see that mm, see this is the border of the redness, right? Roughly. But in between also you can see some amount of redness. So here also you can see redness, but you can see one more patch. I mean, one more area of redness. Let's not call it a patch. So this is actually cellulitis. So now what is cellulitis? Cellulitis is in cellulitis there will be redness, but there is no clear demarcation. So you do not know where the redness. I mean, it is not as clear for you to say that okay, this is where the cellulitis ends and this is where normal tissue begins. That is why it does not have that good a. So these are diffuse margins. The correct medical term would be a diffuse margin, right? And what you can see over here, these are blebs. This is a bleb, right? And the most common cause of cellulitis is streptococcus. So the most common cause for abscess would be staph, that is staphylococcus, and cellulitis would be streptococcus. Now this is again necrotizing fasciitis of the scrotum and the perineum, right? So this is, I discussed this earlier, this would then be called Fournier's gangrene, right? Now what is typical of Fournier's gangrene is you can see this structure hanging out, right? This is the head of the epididymis, this is the testis, and this is the spermatic cord. Same thing on the other side. Now in Fournier's gangrene, the testis is characteristically spared, that is the testis is not involved, right? Okay, so let's see what this image is. So now in this image, you can see red tissue in between, right? And you can see some white tissue or some slough in other areas. So these are the red tissue represents granulation tissue, and the where there's outright slough, that means that there is some infected tissue over there, right? And you can see slough in other areas as well. So this patient, he developed a mixed streptococcal infection of a skin graft with very poor take. What I'm sorry, what does this poor take mean? Poor take means that the graft, it was not taken up by the recipient, right? It was rejected. So very poor take means it was not poorly, it was not well accepted. That would be a better way to put it. Now, see, it is a mixed streptococcal infection. Now, what is important is that before you do any split thickness skin grafting, you have to take a culture, right? And group A beta hemolytic streptococcus, this is a contraindication for doing a split skin graft. So whenever you take a swab, and supposing if you find group A beta hemolytic streptococcus, that means it is a contraindication and you should not do a skin graft. Why not? Because the streptococcus, it has the, so you saw in a previous image also of cellulitis, right? Cellulitis is also most commonly caused by streptococcus. So now the thing with streptococcal infections is because streptococcus, it produces those enzymes of hyalase and DNase and collagenase, it tends to have a very diffuse infection, whereas staph has a very localized infection. This is why staph produces abscess and streptococcus will produce cellulitis. Okay, so now what is seen over here? So this is a linear wound, right? And it looks like an incised wound with some wider separation in between. All right. So this is a fasciotomy wound, basically. Judging by the site of the wound, this looks to be a fasciotomy wound. And you see over here that this wound has been closed. So what happens in a fasciotomy is you are doing a fasciotomy in compartment syndrome. That is, you want to relieve the pressure in the underlying compartment, right? So that there is no gangrene which is happening. the threshold is 30 millimeters mercury. If it is more than that, then that is supposed to be compartment syndrome. Now, once you make the incision and you relieve the pressure, once the wound becomes healthy, if you wait for the wound to heal on its own, it will take forever, right? So, what you do is you can, once the conditions are favorable, that is when you can reoppose the wound and suture it again. So, that is called either called tertiary or delayed primary. So, what are the types of wound healing? Types of wound healing is one is primary, where you suture the wounds immediately. Secondary is you let the wound, you leave the wound open, you let it heal on its own. So there's granulation, contraction, and epithelialization happening in a secondary intention. What is a tertiary intention? Tertiary intention wound is a wound where, or it's also called a delayed primary, where you wait for conditions to become favorable and then you do a primary heal. So now the question arises: what is a split thickness skin graft? Is it primary, secondary, or tertiary? So now split thickness skin graft, you're not doing it immediately, right? You're waiting for the wound to become favorable. So that means you're letting the wound become favorable and then you are closing the wound, whether by stitch or by glue or by graft, you're closing the wound. So then that is also an example of delayed primary or tertiary healing. So again, in this patient, you can see that this is the abdomen, this is the margin, right? This entire thing is the margin, and this is the underlying tissue. So there is a healthy tissue over the fascia as well, and there is no gap. So basically, this wound was left open to granulate after laparotomy for fecal peritonitis. Now it is red, so now it is ready for skin grafting. If you wait for this wound to heal, it will take forever. Secondly, there is some amount of tissue loss, right? It looks like there has been some amount of tissue loss, or maybe there is adhesion on both these sides, here as well as here. So, judging by first appearance, by looking at this, it would not be possible to bring these two ends closer. It is difficult to make these two lovers meet. So, uh, it would be difficult to make these two lovers meet. So, you can cover it with a skin graft. Okay, now this is an ultrasound of the liver which shows a large amoebic liver abscess. There is a large amoebic liver abscess. Now, how do you identify it to be a amoebic abscess? So, first thing is, in an amoebic abscess, it is a round lesion. Let me use a different color. It is a round lesion, right? That is the first thing. Huh? Second thing is, it has a very well defined margin. So, if you were to see this, see, you can see very clearly as to what the margins are. So, it is a well defined margin. Second thing is, this lesion, you can see a black, it looks black, right? So, it looks just like this. So, it is hypoechoic. So liver abscesses are either hypoechoic or hyperechoic. And so what it looks like is, see, you have a hypoechoic, that is the black part. You have normal, I mean not normal, you have slightly darker or slightly brighter rather gray, and then you have the normal thing. So this entire thing, it looks like a bullseye, right? Lastly, all abscesses, whether it is amoebic liver abscess or a pyogenic abscess anywhere in the body. So you would have noticed during your internship that whenever you're doing an incision and drainage for an abscess, the moment you put an incision, put your finger inside, you break all the locules. And how deep do you go? So you will notice that as you remove all the pus, some amount of blood is coming out, right? That is because the abscess, that is the pus, it is enclosed by a very thin layer which has very thin blood vessels. So because of that layer of blood vessels, all abscesses, they have a halo or a rim. They have a halo or a rim of increased echogenicity of brightness. So if you notice over here, see, this entire thing is, it looks bright. It looks bright over here. It looks bright over here, right? And you can see this small flecks of brightness within also. So these are debris or internal echoes. Okay. And one more thing is, it might demonstrate posterior acoustic enhancement. So that means this is the lesion. This entire thing is a lesion, right? But you can see a white thing forming over here as well. This is the posterior acoustic shadow. Now, whenever you get these images in the exam of an ultrasound or an X-ray or a CT or an MRI, there is no need for you to become a or even a slide for that matter. There is no need for you to become a radiologist or a pathologist and to go into that much detail. Your idea is to just identify the image and solve the equation. In many instances, I demonstrated this in the class today morning as well. In many instances, there is no need to, uh, look at the image even. In many of the questions, you can answer the question without even looking at the image. The image is just used as a supplement, which might be put there to confuse you or to misguide you, right? Okay. So now how do you differentiate between, I told you that both a pyogenic liver abscess as well as an amoebic liver abscess, it will have that, the rim around it, right? So how do you differentiate between the two? Now in a pyogenic liver abscess, it is full of pus, right? So internal echoes are more common compared to an amoebic liver abscess. Then septations or loculations are common. This is not location, this is loculation. Septations or loculations are more common in a pyogenic liver abscess. And these are usually, they can be single or they can be multiple, whereas an amoebic liver abscess is usually solitary, right? Margins in an amoebic liver abscess, it is ill-defined. Sorry, in a pyogenic liver abscess, it is ill-defined as opposed to well-defined in ALA. Shape also, it is irregular, it is round or oval. So now when you look at this image again, see it is a fairly roundish image. So you know that this is an abscess and it is hypoechoic with inside. It is, you can also see a rim of, see if you look closely, this is the rim, bright rim, right? The pyogenic rim, and there is some surrounding. You can see there is some changes in the texture of the liver. That is because there is some inflammation or some edema around the abscess. Now, even though I've shown you the differences between an amoebic liver abscess and a pyogenic liver abscess, trust me that in our exam you will not be given a question where you have to differentiate the two only on the basis of an image. You're not a radiologist, right? So you will be given some clue in the question as well, which will help you come to a diagnosis. Okay, so now how do you differentiate between an amoebic liver abscess and a pyogenic liver abscess? Okay, this we already discussed. Huh. So now I told you that a pyogenic liver abscess is usually multiple, but you can even get multiple abscesses in an amoebic liver abscess. So here you can see multiple abscesses. And how do you know it is an amoebic liver abscess? Because here see those septations or debris within are lesser compared to a pyogenic liver abscess. Okay. So now you can see that the bowel has been opacified, right? So when does the bowel become opacified? If it is only in the pharynx, it is called barium swallow, pharynx and esophagus. It is called a barium swallow. When it goes to the stomach, it is called a barium meal. When it is in the rectum, it is called a barium enema. If it is in the small bowel, it is called a barium meal follow through, right? Or a barium follow through. So in this patient, you can see this is the roundworm. All right, this is the roundworm, and you can also see some barium within the roundworm. So this is a barium follow through which shows roundworms. So here, if you see, this is an MRCP. This is the right hepatic duct. This is the left hepatic duct. This is the common hepatic duct. All right, this is the gallbladder. So this is the CBD. So you can see this. Use a different color. You can see this, it looks different over here, right? That is a roundworm, and this roundworm is present within the CBD. Now this is a gallbladder, and you can see this curve, this worm-like structure, that is actually a worm only. So there's a live worm within the gallbladder in this image. Now in this image, there's a live worm within the CBD. See, you can see over here, there's a live worm within the CBD. So in this patient, the bowel has been delivered outside. When you make an enterotomy or when you make an incision in this bowel, you can see the worms coming out. So many worms came out from this patient. Looks like chow mein actually. And if you look closely in this image, you can actually identify the roundworms even before opening the bowel. Okay, so this patient shows left lower limb filariasis or a elephantiasis, right? Now, elephantiasis can also occur of the scrotum. When it occurs in the scrotum, usually the scrotum becomes massive, so the penis, it becomes buried. So you get a buried penis. Huh. So here in this patient, you can see this. There is some amount of swelling. That could be a hydrocele also. But how do you know it is filariasis? Because it is. I mean, see, hydrocele is actually, sorry, filariasis is secondary lymphedema, right? So here you, and how do you know it is lymphedema and not hydrocele? Because you can see these changes on the skin. So you can see this dermal thickening which is occurring, right? So these changes, it demonstrates that it is filariasis. Okay, so this is a CT scan which shows a hydrated cyst of the pancreas. Okay, now how do you know it is pancreas and not the liver? So see, this entire thing is the liver. This is the liver, right? And you can see some gaps. So there is this lesion. It is not in continuity with the liver, right? So what other structure could it be? If you look at this is the tail of the pancreas. So this is the there's a hydrated cyst in the pancreas. Now, one more thing that I would want you to see, you know that this, you know for a fact that these are the ribs, right? These are the ribs. This is the vertebrae. Now, when you look at this lesion, which they have, when you look at this lesion, which they have crossed, right? You see over here, this looks the same bright color as the bones. That means the wall of the whatever that lesion is, it has become calcified, and calcified wall is typically seen in a hydrated cyst. So here again, this is hydrated cyst of the adrenal gland. So how do you identify it to be the adrenal gland? So see, this is the kidney. This is the kidney, and this is present just above the kidney. This is the adrenal gland. So now in this patient, see, obviously the liver is going to end over here, right? The liver will not be present on both sides of the abdomen, but there are lesions which are present on both sides of the abdomen, and you can see that it is loculated, and there is some amount of whiteness or calcification, whatever you want to call it over here, right? So this basically, this patient has disseminated hydatsis of the abdomen. Now again, I'm telling you, there is no need for you to become a radiologist and look into it in minute detail. When you scroll up, you would have seen that I would have given you some pointers on how to identify it, but that is just to help you identify the image. Do not go into too much detail, and do not try to become a radiologist when you're looking at these images. Now, in this patient, this is an MRCP image. So you can see that this is the CBD, right? And so this entire structure over here, this is part of the liver. It obviously can't be the biliary tree, so it is the liver. That is the only explanation. And this is a hydrated cyst. So what you see over here, these are daughter cysts. Okay, and this entire thing, it is communicating with the CBD. Okay, so I've put an image of a water lily over here to demonstrate to you the hydrated cyst of the lung. So in this image, that is in this X-ray, you can actually see it better. So this is the hydrated cyst of the lung, right? So this arrow over here, this arrow over here, then you have this arrow over here. It shows this and it shows this. So what are these? These are basically, it looks like membranes which are floating inside, right? It looks like membranes which are floating inside. And this that you see over here, see, this looks like a water lily. This is the water lily. So you can see one flower. You can see one flower which is present in between. So same thing is seen in this image as well. This is the water lily. So in this image, you can see this is a CT scan. So it's a cut section, so you can see it as a CT scan. This also shows a water release sign. So basically, I'll read the description. While on a high altitude trip, a young mountaineer complained of sudden shortness of breath, cough, and copious expectoration of consisting of clear fluid and flaky material. So basically, there is some pathology which has started to communicate with the tracheobronchial tree. So it turned out to be a ruptured hydrated cyst. The hydrated cyst had ruptured into the tracheobronchial tracheobronchial tree. Yes. So if you see over here, that is this main image. I mean, what is being arrowed? You can see this continuous yellow line within something else. So this looks like a water lily. Okay, so now what is this image? This image shows it is of a leper. It is a patient who has leprosy. So in leprosy, what happens is the leprosy, it destroys the nasal cartilage, right? Because it destroys the nasal cartilage, there is depression of the nasal bridge. It looks like as though the nasal bridge has gone inside. So that is one thing. Second thing that you can see over here is um, if you zoom in both the images, you can see there is no hair. So there is loss of eyebrows. This is called madarosis. That is the loss of eyebrows is called madarosis. And this is seen in leprosy. This is again claw hands and claw toes, which are seen in leprosy. Along with the claw, that is the hyperextension of the metacarpophalangeal joint is hyperextended, and the interphalangeal joints are flexed, right? So along with that, you can also see that some fingers have been lost, some toes have been lost. It has undergone autoamputation. Okay. Now again in leprosy in this patient, so you can see that there is a wound which is on the sole of the foot and some toes are missing. So in this patient and in this left foot, you can see this is a clawed toe. These are clawed toes, right? So this combination is of leprosy. So basically what happens is in leprosy, there is anesthesia of the sole of the foot. Okay. Now in this patient over here, you can see that this nasal bridge has gone deep. So same thing in the poor lady whom we had seen earlier. The nasal bridge has gone in, right? So now when you see a human being, you will see that the nose, it is coming like this. You can see a beautiful bulge over here. That is the nasal bridge on which I can hang my spectacles, right? Now there is an animal which just has these nostrils. There is no nasal bridge over there. That is the lion. That is why these are called leonine facies. So when you look at this lion, see, it looks like as though the nasal bridge has been depressed. That is why it is called leonine facies. And you can also see gynecomastia. See, the key to remembering images is you need to bear in mind that doctors, especially, I am very fond of saying this, doctors, especially surgeons, we lead very boring lives. So we do not have time to go to the zoo. We do not have time to go to any national park or a sanctuary, or we do not have time to go to what is that called? Where you go to see animals in South Africa. I forget the typical term. Anyways, what I'm trying to say is, since you cannot see a lion outside in real life, safari. Since you cannot see a lion in a safari, you start seeing lion and animal and bear and all that things in your patients only, right? And also, since you're a sadist, you want to make the lives of your juniors and your students miserable. So you can see gynecomastia as well as leonine facies. Now this is mycetoma of the foot. So how do you know it is mycetoma? Because you're going to see a classic triad. This triad is, see, you can see a swelling over here. Then there are sinus tracts, and when you express that swelling, you will see the presence of characteristic granules or grains in the discharge. So these granules or grains, what are they? They are aggregates of fungal or bacterial organisms. So um, when it is a fungal organism, it is called eumycetoma. When it is bacterial, it is called actinomycosis or actinomycetoma. This is again mycetoma of the knee, a mycetoma of the head and neck. And here you can see mycetoma, which is in the inguinal region. Now, in this patient, you can see, so let us look at this soft tissue swelling. How do you identify this soft tissue swelling? So you can see over here, see normally the skin is coming like this, right? That is the skin, and within you can see the bone. But in this patient, here you can see there is some opacity. So there is a soft tissue swelling over there, and within the bone you can see a cavity. Here too you can see a cavity, and in the periosteum over here you can see that there is some thickening. So there is some reaction over here, that is the periosteal reaction. This periosteal reaction is typical of eumycetoma. In MRI on mycetoma, you can see something called a dot in circle sign. Now, a normal person like me, when they see this MRI, we can't see anything. But radiologists, when they look at this, they can see a dot in a circle. So, this is the circle, and you have actually this is the circle. I need a smaller size. See, this is the circle, within you have the dot. So, dot in circle sign is typically seen in mycetoma on MRI. So, why is a dot in circles seen? It indicates the presence of grains. Now, what do we have here? So, this is a plain abdominal X-ray which shows large stones along the main pancreatic duct. So, you can see stones, right? These are actually all stones, and this is seen in tropical chronic pancreatitis. Okay, this image, so any cervical swelling in India is considered to be TB, lymphadenopathy, unless proven otherwise. Apart from the thyroid swelling, which you can obviously tell, any swelling in the neck would be considered to be a tuberculous lymphadenopathy, unless proven otherwise, right? So here you can see a cold abscess which is about to burst. Here the cold abscess has ruptured, and you can see a chronic tuberculous ulcer. What is typical is you can see undermined edges. So if you zoom in and you look closely, you will see the skin edge, it can be lifted off the granulation, the tissue within. That is it is an overhanging edge, so that is called an undermined edge. Basically, this is the skin, this is this normal skin, so this is ulcer, right? But undermined edge would be something like this. Now, what do we have here? So, you can see that this is a bowel loop. See, this is the ileum. This is the appendix, right? So, and here you have the cecum. Somewhere over here you have the cecum. So, this, see, you can see how wide this part of the bowel is and how narrow this is. There is a stricture in the terminal ileum, right? And if you look closely, actually, because they're saying it, otherwise you can't identify it. You can see a hole over here. You can see a perforation in the terminal ileum. Fine. So now let us look at bare meal and follow through findings of TB of the intestine. So here you can see this is the ileum. So basically, what I want you to know is that, see, this is the, I have to use a different color. This is the right lower quadrant, right? This is the right lower quadrant. So you should find your appendix over there, right? But because this is the pelvis, you can see the pelvis. So this portion will be your right lower quadrant. So, but you can see that the contrast material over here, it is very, very narrow. That is because there is a stricture in the terminal ileum, and in TB you characteristically get subhepatic cecum. That is, the cecum is pulled upwards, so which causes loss of the ileocecal angle. So normally the ileum enters into the cecum at an angle, but here the ileum is entering into the cecum vertically. So there is loss of the ileocecal angle. So you can see a subhepatic cecum over here, which is being pulled up. So here too you can see a subhepatic cecum, and you can see a chest X-ray findings of tuberculosis. So now in this patient, see, you can see a small, where the arrow is pointing, you can see a gap over here, that is a perforation which is being suture repaired. So this is because of typhoid, and it has happened in the terminal ileum. Acid peptic disease usually happens in the distal stomach or in the duodenum. So now what is this position? This position is the Trendelenburg position. And this is the reverse Trendelenburg. Now the reason I have mentioned this is because Trendelenburg position, we usually take it to mean that the head end is, so this is a person lying down, this is the foot end, this is the head end. Everybody assumes that this is Trendelenburg positions, and so when the head end is lower and when the head end is above, it is reverse Trendelenburg. But as you can see, mentioned Bailey and Love, in the Trendelenburg position, the head end of the table is tilted down on an incline and the patient's knees are slightly flexed, right? So both these things should be there for it to be called a Trendelenburg position. So this is a left lateral position with the patient safely stabilized using stirrups and straps. So now in this image you can see certain incisions. So what are these incisions? So this is a sternotomy incision, right? You can use it for coronary artery bypass grafting, for thymectomy. Fine. B is a periareolar incision. So for example, if you want to remove a fibroadenoma, or if you want to place a breast implant, that would be the most cosmetic incision. This is an inframammary incision. This is a subcostal incision. So subcostal incision is used for open cholecystectomy, and if you want to operate on the gallbladder and the biliary tree. This you can see it is a vertical incision. It is not exactly in the middle, it is slightly away. This is the umbilicus, so this is slightly away. So it is a paramedian incision. This is a transverse incision. Transverse incision is more commonly used in children. Why? Because it causes less respiratory difficulty than a vertical incision. And G, this is a periumbilical incision, right? It can be used in umbilical hernias. This is a gridiron. This is a gridiron or a McBurney's incision for appendicectomy. This is a final steel incision for LSC, lower segment cesarean section, right? Moving on to the adjacent image, this is a Kocher's incision which is used for thyroidectomy. Okay, this is a clamshell incision. So you would have seen those clams, those animals which you would have seen in on TV or in movies or in any web series or whatever, because you have no time to go to the beach. You are wasting your 20s trying to get the PG seat. Anyways, so this is a clamshell thoracotomy. So basically it opens like a clam. That is why it is called a clamshell. Again, this surgeon who came up with this name, I don't think he ever went to the beach. He always wanted to go to the beach, but he was having clams for breakfast or dinner, whatever. So he decided to see a clam in this. That is why he started calling this a clamshell incision. Now, what is this? This incision is called a chevron incision. It is also known as a rooftop incision. So why is it called chevron? Because this chevron, it is an American company, and so American company, I think it has logos something like this. So that is the logo of Chevron. So here you can see that it resembles the Chevron company logo. That is why they've called it the chevron incision. This is the midline laparotomy incision, and this is the inguinal incision. So here you can see scalpel blade sizes and shapes of different blades of different sizes. So what you need to know is this blade, that this is size 11. This is used. You can see that it is a pointed tip. So it is used for stabbing. So it is used for stab incisions, typically used in abscess, in incision and drainage. See, this is a smaller blade, right? So you will use this 15 mm blade for minor surgical procedures. You will use this bigger blade 22 for laparotomy, and for inguinal hernia incision you might use 22, you might use 15 as per your preference. But say for a lipoma sebaceous, you will typically use a 15 size blade. This arteriotomy blade, I mean this 11 mm blade is also used for arteriotomy, that is to make an opening in the artery. Now what procedure is being done over here? Basically when you're suturing a wound, sometimes there is excess amount of tissue at one end, that is called a dog ear. So it is flapping. Again, this guy could have just said extra skin, but he wanted to call it a dog ear, so he called it a dog ear. So like surgeons, we can see dogs and Mars, we can also see Saturn rings, and we can see all animals, all birds, everything is seen in the human body, right? So dog ear is seen over here. And the procedure that is being done over here is repairing of a dog ear, right? Okay, so in this image, what are they doing? So what are they doing to this poor animal? I mean, to this poor patient. So this is the umbilicus, right? This is a nevus. Don't think that this is the nipple areolar complex. This patient has a nevus. So they have held the umbilicus and they are trying to evert it. So this is to gain access to the abdomen via open technique of creating a nevus. So you can see over here, they have held this. This is called the little forceps. The little forceps, they are everting the umbilicus. Here they have made an incision over there. So see here, they've gone deeper and you can see this gap over here. This is they've gained access into the peritoneal cavity. So here they are widening the gap. So under vision, they have placed a trocar and this is called the Hassen's technique, modified Hassen's technique of pneumoperitoneum. It is mentioned over here. Modified Hassen's technique. So this is the little wood forceps that is used over there. This is how it looks like. This is the Veres technique. So this Veres needle, if you notice, okay, so there are two ways of holding these trocars for laparoscopic surgery, right? So this Veres, this is called he's holding it like a dart, right? But the other trocars, it is held with a pistol grip, right? So you can see this Veres needle over here. See, this is the beveled edge. There is something coming out, which again goes back in. So this is basically a safety mechanism which prevents the underlying bowel from being injured. So this patient also, he's holding a Veres needle just like a dart. Now in this patient, they are doing a laparotomy. That is, they are opening the abdomen. So the patient has made a, I mean, the surgeon has made a midline incision. As so, this is the subcutaneous fat. This white thing that is seen, that is the sheath. The sheath is being opened. The green is, I think, the peritoneum. It is a peritoneum. So this is the instrument. They've held up the peritoneum and they're making an opening in between. Right. Okay. So now let us look at some types of needle. So basically, what you need to know for needles is when you look at the tip of this needle over here, when you look at this part, that is called the cross section, right? If it is shaped like a triangle, it is called a cutting needle. If it is, this is used for cutting, for suturing. If it is shaped like an inverted triangle, then this is called a reverse cutting needle. Whereas if it is round like this, it is called a round bodied needle. So round bodied needles are used for peritoneum, muscles and fat where you want less trauma. But cutting needles are used for aponeurosis and for skin you usually use reverse cutting. So here, what is the type of suture that is being mentioned over here? Actually, I'll just take a quick break. I'll see you in 5 minutes. Albert. So let's continue. So what kind of suture is seen over here? So you can see that these are, see, this is a one stitch, second stitch, third stitch. So this is a interrupted suture. Next, is it a matrix or is it a simple suture? So it is piercing or biting the skin in only one place, right? That is why it is called a simple suture. Now here I want you to see one rule over here. See, the as a rule of thumb, that is generally the distance of insertion from the edge of the wound. So basically, if the thickness of the wound, that is the depth of the wound, is x, right? Then the distance between two sutures should be 2x. That is between. So supposing if you are asked a question as to, if say this is a wound, how many sutures should you place, right? Or at what distance should you place those sutures? So there are two ways of looking at it. One way is you put a suture in the middle, then again here in the middle, again here in the middle, depending on that. Another is if you want to start at one edge, at one end, you will place sutures at a distance which is approximately twice the depth of the wound, that is 2x. Then when you're taking a bite, how far from the wound edge should you come? So you should come as far as the depth of the wound. So you can see over here, this is a bite, this is a bite, right? So and this is x. So basically you are as far from the wound as the depth of the wound is. Now then there is something which you need to know called a Jenkins rule. Jenkins rule basically says that when you're giving a continuous suture, the length of the suture, it should be 4 times the length of the wound. So length of suture to wound should be 4:1. So here you can see that there is a knot over here and the thread is just coming in, going out, coming in, going out. This is a continuous suture. So this is a matrix suture. How do you know this is a matrix suture? So you can see that on each side there is it is entering or exiting the skin at two places, 1 and 2. So it is a matrix suture. Okay, so now how do you know whether it is a vertical suture or a matrix suture? So now you are standing. So now supposing, say, if, see, this is my phone. Supposing if I'm standing over here, this is the right side of the patient, right? Now when I place a suture, obviously I will start putting, say this is the wound, right? So I am going to take a bite over here. I am going to take a bite, I come out. Once I take a bite, the direction which I move my needle. So here, since I am on this side, after take out a bite which is at a distance x, which is the same as the depth of the wound, I am going to take the third bite. In a matrix suture, see, in a simple suture, I will take 2 bites and I'm done. But in a matrix suture, once I take the second bite, I have to go close to the wound, I have to come out again, right? So that is called a matrix suture. Matrices are two types. One is a vertical matrix, one is a horizontal matrix. Vertical matrix and horizontal depend on the direction in which you move your needle after you take the second bite. That is after you come out this side. So I enter over here, I come out over here. Now I have to move my needle. Supposing, say, if I move my needle again in the same direction, so I'm moving it vertically. That is why it is called a vertical matrix. But now if I were to move the needle slightly sideways, so I'm moving it in this direction, that would be called a horizontal matrix. So here, it is in the same plane, right? So this is a vertical matrix. See, this is a horizontal matrix. This is a subcuticular suture technique. So this is the incised wound. The wound is coming out like this and it is going in this direction, right? So this is a subcuticular suture technique. This is used for cosmetic wounds because of very cosmetic appearance. Basically, you would have seen that some people, whenever you see scars, you will see a linear scar in between, right? But you also see dots on either side. That dot represents the bite marks. In a subcuticular suture, there are no bites on either side of the wound. That is why it is a cosmetic scar. Now here you can see the layers of the abdomen. So abdomen has 9 layers. This is the peritoneum. This is the posterior rectus sheath, 3 muscles. You have the anterior rectus sheath. Then you have the 1, 2, 5, 5, 6. This is the subcutaneous fat, and you have the skin. Subcutaneous fat, again you have campus and you have scarpa's fascia, right? So you have totally 9 layers. So here you can see that they have placed a stitch in the posterior rectus sheath, one in the anterior rectus sheath, and one in the skin. So um, this is a layered closure. So you're closing it in layers, and sometimes you might have to close all the layers at once. That is called a mass closure of musculoaponeurotic layers. Now, supposing you were to take a bite, so here you can see there are two layers, right? One layer and two layer. Skin is being closed separately. Now, supposing if you were to take a stitch which would incorporate all these layers at the same time, what would that be called? That would be called a tension suture, and that would be done in burst abdomen. Okay, so now there are two types of diathermy. One is a monothermy and the other is the monopolar and the bipolar. So what is this monopolar? Monopolar, now supposing say this is the cautery, right? Wherever I touch this, I am going to place current. I mean, I'll be burning or cutting the tissue. That is the direction where the current is flowing, right? That is why. So since there is only one tip from which it comes out, so it is a monopolar. Now in a bipolar, you hold it like a forceps, right? So the current is flowing from one, it is going to come from this limb. Suppose you're holding tissue in between, it's going to go to the tissue, it is going to come out of the other limb. So that is a bipolar. What is the main difference is bipolar is more safe, right? Because in a bipolar, you are in control of how much tissue you are burning, right? But in monopolar, that is not in your control. Now, see, in bipolar, I told you that in order to complete this circuit, so if you remember from your physics days, when to complete a circuit, it has to flow in. I mean, the circuit should be complete for the current to flow, right? So in a bipolar, it is getting complete by the tissue in between. What about a monopolar? So in a monopolar, during your internship, you would have noticed that just prior to the OT technician, or in some colleges, maybe the PGs have to do it. You have to place a cautery plate which is in contact with which is in contact with the broad surface of the patient, right? That helps complete the circuit. Okay, now let us look at the topic of drains. So now this is a corrugated drain. So this looks, because of its description, is called a corrugated drain. This is a closed suction drain. Why is it called and see, you can see these arrows over here. That means when you are going to when you're going to charge the drain, you're going to compress it like this. So this acts like a vacuum. Because it acts like a vacuum, it is called a closed suction drain, right? This is also called the trade name that is usually used is a Romovac, right? A Romovac, or it can also be called a Minivac. Now here you can see the drain tube, the drain pipe coming, it is going into a bag, right? So what is this called? This is called the ADK, that is the automated drain kit. Here there is no suction, it is just coming out of, so here it is coming because of capillary pressure. It is coming because of capillary pressure. And also the pressure in the abdomen, it is negative, right? There is negative abdominal pressure, and at atmospheric pressure it is 0. So because of that pressure difference also, fluids can come out of the abdomen. Now this is a T tube. T tube, as you can see, it has been inserted in the common hepatic duct or common bile duct, to be more specific, in the supraduodenal portion of CBD, right? So T tube is usually placed in the common bile duct after you've done any intervention in the CBT. You might have made an opening to remove stones, or maybe when you're doing a lap cholecystectomy, supposing if there's a trauma and you want to repair it, you might have to use a T tube. It will help maintain patency, it will prevent stricture formation. So what do we have here? So here, if you notice, see, you can see these lines. This is because of valvulae conniventis. Valvulae conniventis. All right. This is seen in the jejunum. and this is more commonly seen, or more prominently seen rather, after in small bowel obstruction, right? And you can see over here that these bowel loops are dilated. So dilation of bowel loops is also seen in intestinal obstruction. Now here you have, so this is the outline of the esophagus, right? And here it is narrowing. So basically there's a malignant stricture because of esophageal carcinoma. So some surgeons, when they saw this, they thought it looked like a, so this is a bird which is pointing downwards. They thought it looked like a bird's beak. So they called it a bird's beak appearance. Other surgeons who probably have spent more time looking at rats, they thought it resembles the tail of a rat. So depending on what you see, you can name it. Tomorrow, if you become famous and you give it a different name, I am sure they will give it, they will call it that name also. Okay, what do we have here? So see, this is the renal pelvis. These are the calyces, right? And this is the ureter. Huh? And so here on this side, you can see that the calyces are slightly separated, right? And there is some lesion over here. So this is a transitional cell carcinoma on the left hand side. Right hand side is normal. Okay. So this is a transverse ultrasound image of the liver in a patient with colorectal cancer mets. So you can see this lesion over here. So a solitary mets is seen, right? There's only a one lesion, so it is a solitary lesion. Now, when you look at liver mets from the colon, from colorectal cancer, they are typically hypoechoic. So they are black, but they can be isoechoic. They can also be hyperechoic. Usually they are hypoechoic, right? Then if you see these lesions, they do not have that well defined border. So if you see over here, here the border is very well made out, right? But here I am not so sure. I have to take a guess as to where the lesion is ending, right? So all the borders, so for any cancer, the borders are not that well made out, right? Second thing, you can see it looks like a target, or again this, the surgeon who saw this, or the radiologist, whoever he was, he seemed to think that this looked like a target. He just could not describe it just by the merit of English. He had to use a term. So he said this looks like a target. So he called it a target sign. Now, if you have multiple lesions, that means there are multiple liver mets. Okay. So what do we have here? So here you can see that this is, you can see this red and blue. So red and blue means it is a Doppler ultrasound. So it red indicates it, I mean, red and blue indicate the direction of blood flow from the heart, right? Red is away from the heart, blue is towards the heart. So this is basically a Doppler ultrasound of the portal vein, and this shows, I'm sorry, this shows portal vein in the, I'm sorry, I think I got overexcited. Anyway, so this is the portal vein, and this demonstrates the direction of blood flow. So this demonstrates uh, uh, normal blood flow. So how do you know it is normal blood flow? So normal blood flow is basically, it is hepatopetal, so blood is flowing towards the liver, right? So that is why it is normal blood flow. Okay, so what do we have here? So see, when you want to see, I am not a radiologist, neither are you, and I can't identify these images, neither can you, but we both have to find the answer to these questions in the exam. So how do you identify which part of the body this CT scan is showing? So this is the vertebra. This is easy, no problem with this. There's a huge solid structure over here. I think that this is the liver. There is no other structure which is this big, and there's a huge gap over here. So this contains air, so this must be the stomach, right? These are the two kidneys. This is the right kidney and the left kidney, right? And uh, so what is next to the liver? What is just positive to the stomach? This is the pancreas. So then this makes this the pancreas. Now, so basically when you're seeing the pancreas, this is dilated, right? And that is, it is edematous. I'm sorry, not dilated. It looks bigger because of edema. Also, you can see over here that there is some the color of this. See, if you watch 50 Shades of Grey, you can understand radiology, because these are all in shades of grey, right? So when you look at this shade of grey, it is the same over here, right? It is going over here as well. It's coming over here. It is coming over here as well. So where do you see the accumulation of fluid around the pancreas? You see it in acute pancreatitis, right? So there is extensive peripancreatic fluid outside the, surrounding the pancreas, which makes it the peripancreatic fluid or 50 shades of grey. Now, this is obviously a CT scan of the skull, right? So you can see a lesion over here, and you can see it is next to this skull, so it is near the dura mater. So it is from the meninges, that makes it a meningioma, and you can see this, right? This is called a dural tail. When I was preparing for NEET PG, they had asked this question a couple of times as to what is dural tail sign. So till I was told, I did not know that this is a dura and this is tail. Those days we did not even have smartphones, so it was very difficult. Anyways, this is the meningioma, and you can see this tail-like structure over here, right? So this is called the dural tail sign, which is typically seen in meningioma. So this is an MRI. So how do you know this is MRI and this is CT scan? Very simple. When you look at the bones, look at the skull. See, this is very bright, right? That is CT scan. It is dull, so it is MRI. See, MRI will give you very good soft tissue detail. So when you look at this image, it is obviously clearer than this image, right? So that is why it is an MRI. And MRI brain, obviously it will be clearer than a CT brain. So you can see a lesion over here, and this time there is no tail. So this is some other tumor. So this is an oligodendroglioma. In your exam, you will not be asked to identify what tumor it is. It's not that they will give you this image and they'll give you 4 options to identify the tumor. I've just put this image over here to try to show you what a tumor looks like. Here, see, you can see in this arrow, this is very simple. So you have these successive vertebra and you have the discs in between. But here you can see that this disc is protruding slightly outside. This disc is protruding outside and is causing some effect, some pressure or some impinging effect. Not impinging, it is causing some pressure on the spinal cord, right? So this is disc herniation, it is intervertebral disc prolapse, right? Okay. So now let us look at this image. This is again a MRCP. So this is the right hepatic duct, this is the left hepatic duct, this is the common hepatic duct. Fine. Okay. Then this is the gallbladder, and you can see some defects over here. Where this arrow is seen, you can see some defects over here, right? Filling defects. So why is there a filling defect? Why is the filling defect seen? Because there is something within that tubular structure. So you can see these filling defects over here, right? So filling defect means that there is something within the lumen of that tubular structure which is not, so there is something which prevents the contrast material from occupying that space. So if it is in the distal CVD, it is usually because of a stone. So there are multiple calculi. This image shows multiple calculi in the distal CVD. Now what image is this? So this is a bone scan. So you can see all the bones, and this is a bone scan, and you can see that in certain places, it is more black than other places, right? So basically this is a patient who has got skeletal mets. Yes. Bone scintigraphy in a patient with carcinoma of the breast illustrates bony metastatic deposits. So these deposits are there in the pelvis, in the wrist, in the vertebra, in the skull, in the ribs, everywhere. Okay. So I wanted to show you this image. But so today morning when I was discussing one of the questions which was asked in the INI-CET exam. So basically an X-ray was given and you were asked to identify whether it is tension pneumothorax or hemothorax. So since we obviously cannot get the exact image that was asked on the exam, let us look at all those X-rays. So here you can see where these arrows are present, right? What these arrows are showing. See, this is the rib. This is the rib again over here. So there is some fracture of the rib over here, right? So if there is fracture of the rib, you will obviously get hemothorax, right? If there is underlying lung injury, you will get pneumothorax. So here you can see uh, see if you were to compare this side and this side, you will notice that there is some small pockets over here, right? This is indicative of surgical emphysema. Sorry, subcutaneous emphysema which is present. It is also called surgical emphysema because that is air present in the subcutaneous tissues. Along with this, you will notice that this cardiac shadow, it has been shifted towards the right. So there is some shift, mediastinal shift which is happening. Also, if you will recall, the right diaphragm, it is slightly lower than the left. So it is slightly higher up than the left, right? Because of the presence of the liver. But the diaphragm, I mean, it is, see, this is one lobe on the right hand side. On the left hand side also, you should have seen the lobe by now. The dome of the diaphragm, so not lobe. You should have seen the dome of the diaphragm by now, but you're not able to see this. So that means there is something present in the left side which is causing the mediastinum to be shifted towards the right. It is also displacing the dome of the diaphragm downwards. That means there is some tension in within the pleural cavity which is causing these effects. So it is a tension pneumothorax. Okay, so what is this? It looks very complicated. So let us simplify it. So this is the pelvis, right? Easy enough. This is the pubic symphysis. This that you can see this white, there is some contrast. That means this is the urinary bladder. So far we know that is the urinary bladder. So this should be what is below the urinary bladder. That should be the contrast. Now the contrast from the urinary bladder, it should have come out in a straight line. But here you can see it is not coming in a straight line. So that means, and the contrast is moving out. That means there is some injury because of which the contrast is leaking out, right? So there is some extensive injury to the urethra which causing extravasation of the contrast. Now, along with that, I can also see some pipes over here. So what are these pipes? I mean, some rod-like structures. These are rods only basically. So these are external fixators which have been put in by the orthopedician. Okay. So now, so far you have known that extradural hematoma will cause a biconvex appearance or a lentiform shape. So this image that you're typically shown is something like this, right? But now in this patient, let me put a scale to help you identify. But now in this patient, see, I've put the scale exactly in half, right? So what shape is this now? See, this is also actually because of the presence of scale. See, it is also coming in this direction, right? So this is also lentiform shaped. See over here. So when they come together, so actually, I mean, I don't want to tell in class what this looks like, what it reminds me of. But anyways, what it actually is you can see that it is a extradural collection which is present on both sides. So it is present on the right as well as on the left. Achha, one more thing is whenever you are seeing a CT scan, right? So imagine the CT scan, the image that you're seeing is always from the foot end of the patient. So when you see it from the foot end of the patient, obviously the right will be on your left and the left will be on your right. So here you can see a bilateral frontal extradural hematoma. So see, this is the skull bone. Oh, let me remove this scale. So this is a skull bone, and you can see this is also a skull bone. So what is it? So there's some fracture has happened and it has gone in. So it is a depressed, it is a skull fracture with a depressed component, right? Now what is this? Okay, so this is an MRI. This is an MRI or a CT scan. So like I told you, you can see these bones, right? These very bright structures. Huh? So these are not, this is obviously not the CT scan, it is an MRI, right? Sorry, it is not an MRI, it is a CT scan because these bones are, you can see these bones, it is bright, right? Now, this is the liver, this you are sure because it looks like the liver. So this is the right kidney, this is the left kidney. Right kidney is slightly lower compared to the left because of the liver. This much you can follow. And this is the dome of the diaphragm on the right, the dome of the diaphragm on the left. So if there is liver on this side, if there is liver on this side, yeah, what will you have over here? You'll have the spleen. Now, but this is the normal spleen. See, this is the normal spleen, right? And this is the hilum of the spleen. This is the hilum of the spleen where the splenic vessels enter and leave. So, but here you don't see the spleen. Firstly, you don't see a small spleen, and you see a lot of varying, many shades of gray. You are able to see, right? So, when you can see many shades of gray, that means there is some bleeding which has happened, and it's probably because of a shattered spleen. So, it is grade 5 splenic injury, the treatment of which is splenectomy. Okay. So, what do we have over here? So they are showing you they've put three arrows over here, right? So one arrow, two arrow, three arrows. What are they trying to tell you? Now, even a dumb person like me can tell that this is the kidney. This is the right kidney, the left kidney. Now, a person who is dumber than me will be able to tell that since this is right kidney, this is left kidney, but there's a difference. So you can see white over here on the right hand side. There is no white on the left hand side. So why? That is because there is on the right hand side the contrast is going easily. Contrast is getting excreted easily, but on the left hand side there is no contrast happening, right? Then someone who is even more dumb can tell. Let's see, you can see vertebra over here, but you can see over here that these vertebra there is some tissue in between. So there is a lot of vertebral fracture that has happened. So if smart people like you and me are able to see these many differences, this rubber is giving me a lot of problem. So if smart people like you and me can identify this much, a dumb person, what should they, or what should a smarter person be able to identify? This is the liver, but you can see a different shade of gray outside it. That means since there are so many injuries which have happened, this is probably blood which is accumulated outside the liver, right? So basically radiology is nothing but 50 shades of gray. Tomorrow when if you get a radiology seat, you should remember this, that radiology is nothing but 50 shades of gray. Okay, so what do we have here? So what does this arrow show? This arrow, it is outlining, this is the stomach. How do I know it is the stomach? Because in this left upper quadrant, what else will there be, right? This is the stomach. And why have they outlined it? Arey yaar. Why have they outlined this? So you can see air inside and you can see air outside. So when is air seen both inside a viscera and outside a viscera? In perforation, right? So what is it called when there is air both inside and outside? It is called Wriggler's sign. Okay. Now, what is Wriggler's triad? Wriggler's triad is seen in gallstone ileus, right? Just remember that. I won't go into detail. Wriggler's sign is seen in hollow viscous perforation. Wriggler's triad is seen in gallstone ileus. So here, what can you see? This arrow, it is showing you air under the diaphragm. How do I know this is air? Okay, supposing I am very dumb, I don't know what that this is air. So see, you can see some, this looks just like this, or like how in the lungs you can see some air. Similarly, you can see that there is some air over here, right? So there is some air under the diaphragm, huh? So there is some perforation of the, some hollow viscous has been perforated. What else do I see along with that? So I can see that, see, this is the lung shadow, right? This is the lung shadow. That means there is some amount of air over here as well. So there is a pneumothorax. Fine. Now normally on the right hand side, yaar, this rubber is, normally on the right hand side, you should see a gastric air bubble. But what do I see here? This looks like a bowel loop. So when will a bowel loop be present in the thorax? When there's a rupture of the diaphragm. So here there is pneumothorax and air in the diaphragm. So presumably there has been a traumatic rupture of diaphragm. Okay, so what do I see over here? So the location of this is where? It is in the right lower quadrant. So right lower quadrant, what do they want to ask you? They usually want to ask you appendix, right? So you know this, that there is an appendix for even before looking at this image. Okay. So how do you know that? How do you confirm that this is appendicitis only and nothing else? So see this over here. This is the shape that it is taking, right? So it is slightly thickened in some places. So it is because of edema, presumably, it has become thickened, and you can see some different shades of gray around it, right? So that is because of fat stranding. So this is an image which I took online just to illustrate what an appendicitis looks like on CT scan. So see, this is dilated over here, right? And there is fluid which is present. The dilation is more than 6 mm. Now, along with the appendix, you can see that there is so many shades of gray around it because of fat stranding. And here, I can see there is a very bright white like thing seen within it. So what is that called? That is an appendicolith. Okay. So here they are pointing to a region which is present in the hypogastrium. Okay. Even a dumb person like me can tell that this is the bladder, gallbladder, urinary bladder. Okay. Then, so what do I want to see just above the, what is present above the bladder? That is the sigmoid colon, right? So what will they ask you as a NEET PG aspirant from sigmoid colon? They will ask you a diverticulum, right? So if you see over here also, you can see a lot of, along with the, so you can see this over here, the entire black thing, it resembles this only. That is, there is some air over there. So how did the air reach over there? Because there is some perforation secondary to a diverticular perforation. Okay. So here also, see here you can see the diverticula clearly. So see this small that white, this air, that is because of the perforation, right? But you can also see it like this. See, this is the bowel wall lumen. It is coming like this. See, it is coming like this. So these are diverticuli. Okay. Now, whenever you see an image where you see these concentric circles, okay, wherever you see these concentric circles, that means it is an endoscopic ultrasound. Fine. This much please bear in mind. Whenever you see these concentric circles, it is an endoscopic ultrasound. So these black arrows, you can see there is some lesion over here. Fine. So this lesion is seen on endoscopic ultrasound. So it is on the wall of the lesion. It is on the wall of the viscous. So there must be some tumor over there. Fine. So this is an endoscopic ultrasound in gastric cancer, where since it is going beyond in certain places. So it is infiltrating the entire wall of the stomach in this case, right? So same thing, same patient. This was an endoscopic ultrasound. Same patient, when you take a, see, you can see this bone. So it is a CT scan. So this is the stomach, and you can see that there is some thickening happening over here, right? This thickening, it is happening in the lesser curvature. Huh? So that there is a tumor over there. Now, whenever you see an image, which is, see, radiologists have 50 shades of gray. But whenever you see a colorful image where you see blue, you can see yellow and some other colors of the rainbow. So this is nothing but nuclear medicine, where there is a FDG PET scan, that is a fluorodeoxyglucose PET scan. Now I can see this in two places. Bright light I can see in two places for sure. One I can see over here in the arrow, one I can see over here. So this, there is a, this is CA lung, and here there is mets in the lymph nodes. Fine. Now you will ask, sir, why is it not, why is this not breast, CA breast? If you, just by looking at the image. So in breast cancer, you will get mets in the region of the axilla, right? And you will not get mediastinal lymph nodes. So it is not CA breast. Okay, so what is this? So basically this is nothing but a endoscope. So one of them is a gastroscope, one of them is a colonoscope, right? So they both look similar. So how do you identify this in the exam? You bear in mind that where you see a long tube-like structure which is coiled, that means it has to travel quite some distance. Now the distance from the incisors to the GEJ, that is the gastric junction, it is 40 centimeters. So it has to have so many coils. That is why it is an endoscope. So this could be an upper GI endoscope. The other one also, it is quite coiled because it has to go from the anus into the rectum, sigmoid colon, then the descending colon, transverse ascending colon. It has to travel quite some distance, right? That is why it is present in coils. Now, what do you see over here? So, don't think that this is papilledema. When I used to see this for the first time in my, when I was preparing for my MS exam, I thought maybe this is papilledema. Anyways, jokes apart, this is not papilledema. Why? See, you can see some black over here, right? That means this structure is going inside. So it is an endoscope image. Now what you can see over here, see, you can see a different shades of red. Huh? This is slightly brighter, this is slightly lesser red. So this is the gastroesophageal junction. Fine. That is the gastroesophageal junction. Now, so this is the scope. This is the scope. Now in the other three images, are you able to see the scope? No. You can see the scope in this image. Why? What is so special? So what they do in, so here, what is the only, which is the only scenario where you will see the scope in an endoscope. So now you've inserted an endoscope. Okay. This is the stomach. Wait, let me draw it again. This is the stomach. Now this is the scope. I want to see the fundus. Fundus is this part, right? Fundus is this part. Let me use a different color. This is the fundus. This is what I want to see. So my scope, whenever it comes in this direction, again I have to retroflex it. So I have to put it in this, I can flex it in this direction. So when I put it in this direction, this is what I am seeing, but I can also see this. So this is why you can see the scope, and the area that is being seen is the fundus of the stomach. Fine. Okay. Then now, when you see this, see, this looks very plain, whereas here you can see a lot of folds. Huh? So then how do you identify what is what? So see, you can see that there is something which is going beyond, right? So there is some continuity, and this is definitely not the GJ, because the GJ it looks like this, and in GJ you have these palisading vessels. These are called palisading vessels. It has a layered effect. Okay. Here that layer defect is not there, so I know it is not the GEJ. It is going beyond, and I can see that it is of slightly this shape. So this is the pyloric antrum. This is the duodenum. Again, you are not doing DM in medical gastro, so your idea is not to become a gastroenterologist. No need to know all this in detail. I'm giving you the very bare basics. I'm telling you this. You can see the duodenum. Okay, so here you can see the esophageal varices. See, all these dilatation that you can see over here, these are all varices, right? And here, what are they putting? See, you can see this black thing, and above it, it has bulged out. So they've put a rubber band and they've done band ligation of the varices. So this looks like a watermelon, and watermelon is seen usually in GAVE, that is gastric antral vascular ectasia. Okay. One more thing, whenever there is bleed in the upper GIT, you always coagulate that bleed using a argon plasma coagulation. Fine. So moving ahead, here you can see a pool of blood. See, you can see uniformly red. So where do you get a pool of blood? Where there is a gastric ulcer, right? So this is a gastric ulcer where there is active bleeding going on. Now, so what they did over here is, see, I can't see this and identify, all right. I'm reading it from here and identifying. So here they have injected adrenaline to achieve hemostasis. Fine. So once you inject adrenaline, the bleeding stops. So you will notice that this pool which was present over here is no longer there over here. Because of peristalsis, it has taken the earlier blood downstream. Now, when I first saw this, I thought this is lipstick. I thought this is a lipstick handle. And I thought this patient has swallowed a lipstick. But that is not what this is. If you look carefully, these look like clips. See, this is a clip. So these are hemoclips, and hemoclips are applied to prevent rebleeding. Now, here, this is the pylorus, and this is apparently narrowed. So this is narrowed. So there is a pyloric stricture over here. This pyloric stricture is dilated through a balloon. Now you can see this part also. Therefore, it is called a through the scope balloon. Common sense fairly so far till now. Then what procedure do you see over here? Now you can see something is being introduced via the mouth, which is then going into the stomach, right? And at the same time, see, there is a gap over here. See, there's a needle which is stopping over here, right? So this is one, this is the other. So these two levers are made to meet in the stomach. So why are these two levers being made to meet in the stomach? Because they're doing a percutaneous endoscopic gastrostomy. So this is the percutaneous part. This is the endoscopic part, right? Now what is this? So when you see this, see, it looks something like this, like a tubular structure. And if you zoom in, you can see it is looks like a mesh. So this is nothing but a stent which has been placed in the esophagus. You can see this is what it looks like. This is nothing but a stent, stent, sorry, which is being placed in the esophagus. Okay. So now what is this? So basically here, it looks like this part has become, it is slightly elevated. So it looks like there's a depression over here. The entire thing is red, right? So basically what happened here was, there was, whatever was present over here has been excised. When it was excised, it has left a clean bleeding base deep to it, right? So basically, this patient has undergone, array yaar, what is this problem? So basically, here you can see uh, the whatever lesion was present over here has been excised. Okay, so we'll take a small break over here and we'll resume in 2-3 minutes. So continuing, here you can see a pill, and you can see some images. So this is a pill endoscopy, right? And pill endoscopy is typically used. So supposing if a patient has a source of bleeding in the GI, which is not able to, which is not being localized by the conventional methods of endoscopy, you can use that. You can then use a pill endoscopy. So here you can see a dilated blood vessel. This is an angioectasia, right? So let's move ahead. So here you can see the stomach. You can see one balloon, and you can see here you can see two balloons. So this technique is called a double balloon enteroscopy, right? This is a double balloon endoscopy. And how do you advance the endoscope? You advance it by using the push technique. Okay. So what is seen over here? So this is an ERCP image. How do you know it is an ERCP image? Because of this. This is the endoscope, and here beyond it you can see the biliary tree. Now this that you can see over here, this is the stent that is being inserted, right? That is inserted during ERCP. Fine. So what do you see over here? Hmm. Okay, in this what is important is these two images. So here where the arrow is going, this is, it looks like something is going inside, right? So this is the orifice of the appendix. See, this image will definitely not be asked you in the exam. I have placed it over here just to give you some orientation of what endoscopy looks like. So here you can see the appendix lumen going inside, and wherever you see this, right, the small, it looks like very soft, right? So these are nothing but villi in the terminal ileum. Okay. So coming to chromoendoscopy, what is this? You can see a blue dye, and you can see an image without the dye. So this is called a chromoendoscopy. Chromoendoscopy. So here they have taken the help of a dye to locate certain tumors. So now this is the tumor, but we are not sure as to the image is not that clear, right? So whenever you use a chromoendoscopy, basically the chromoendoscopy, it, see, this entire thing is a lesion. So whenever you place the dye, what happens is normal tissue, it stains, and wherever there is lesion, no stain or little stain. Here also you can see chromoendoscopy being used. So basically the chromoendoscopy typically highlights the normal structures rather than the lesion itself. So here I can see this is an image of the colon. How do I know it is the colon? Because if you go closer, you can see villi over here. See, this looks like villi. And you can see it looks like a tree actually. It looks like a tree. So what is this? This is nothing but angioectasia of the colon. So here let us see what the arrow shows. The arrow over here, it shows this is nothing, it looks like a mesh. So remember, this is nothing but a stent. So this stent has been placed in the descending colon, probably because there was some obstruction. Again, wherever you see these concentric images, it is a endoscopic ultrasound, right? And you can see a lesion over here, which is the tumor. So one more point that they've mentioned is, see, this is a ragged edge. It is not a uniform edge like this. It is something like this. So a ragged edge, which is suggestive of invasion of the outer layer. Now, what are these devices? So this is a Da Vinci robot. How do I know this is a Da Vinci robot? Because a Da Vinci robot has many limbs, many arms, many hands. All right, this is the Da Vinci robot. So this is a surgeon console. That is, a surgeon sits over here and he operates this. This is the surgeon console. This is the Da Vinci robot, right? And this is the vision card. You can see this TV over here where you can see and you can operate. So this is robotic surgery. So You can see Da Vinci robot being used, 1, 2, 3, 4, 5, 6 hands, right? Actually, it is 1, 2, 3, 4. The same thing which was seen over here. 1, 2, 3, 4. So this is the Da Vinci robotic system. There's one more robotic system which is called the Vercius robotic system. The Vercius robotic system looks different and it has 3 limbs. So what is being done in this image? So this is the trocar, and you can see there are blood vessels on both ends which are bleeding. So they've placed a suture which is used to stop bleeding. So now what are you seeing over here? So here what you can see is you can see a very bright green color, right? And so that means there has been a dye which has been administered, that is the indocyanine green, right? And this is nothing but a robotic assisted lung segment. Like actually, this is not be asked in exam. The only reason I put it over here is to demonstrate this, the purpose of the dye. Okay, so what is being done over here? Actually, in AIMS, last few years, they are very fond of asking what test is being done, identify this. So if they can ask you per kidney endoscopic gastrostomy, since these images are given in Bailey and Love, I thought of just including this to because this might be asked in the exam. Now, this is a normal bronchoscope, right? This way you can see over here. This is the trachea, and this is the left bronchus. This is the right bronchus, right? So here, what you can see, this is an artist image. This is the virtual bronchoscope, and here they are showing you the entire thing. So this is a 3D map dynamic bronchoscope. So what is being done over here? So what is being done over here? See, this is some sort of image for capturing a, this is some sort of device for capturing an image which you can see over here. So if you zoom in and see, you will see this is the cardiac shadow. Cardiac shadow, this is the lungs. These, sorry, this is the vertebra. These are the lungs. So there is some surgery going on in the lungs, and see, they've made an opening over here. So this is VATS, or video assisted thoracoscopic surgery, right? And they have placed a marker which will then guide them to resect the tumor. That is called a fiducial marker. Fiducial marker is nothing but it can either be inserted by the doctor, or it can be a natural marker which is present in the body, and any anatomical landmark. So that will help to orient the surgeon and to resect the tumor. So what do we see over here? So this is an image from the colon. You can see a growth over here. You see there's a growth over here, right? So what does this show? A colon from a patient with FAP where it has been opened longitudinally and the brown appearance reflects adequate fixation. Fine. Numerous polyps and a carcinoma are present. So all these things that you can see, these are polyps. This is the carcinoma. This also appears to be a carcinoma. Actually, only these two are not required for your level. So what are these called? So basically, whenever you do a biopsy, right, and the specimen goes to the pathologist for biopsy, the pathologist, he prepares it in something called a cassette. So many times these patients will come with either a glass slide, or he'll come with these small plastic things which are called cassettes, right? And in cassettes, what happens is the pathologist has taken what he feels is the best sample. He's placed it over there according to groups, and so this is then used to make a diagnosis. So you can see over here, this is a paraffin wax block. This entire thing is a paraffin wax block which is being cut. This is the blade. This is used to prepare the cassette. So this is a device where both the senior pathologist and the junior pathologist, they can see the sample simultaneously. This is called a double-headed microscope. So you can see different colors of inks over here, right? You can see 1, 2, 3, 4. You can see different colors of inks. So why are these different colors of inks or dyes being placed? Because so when you send this specimen to the pathologist, he wants to know the margins, right? which margin is positive for oncological specimen. That is why he puts these different colors. So if you zoom in over here, you can see yellow ink over here. This yellow ink corresponds to the dye which is placed over there and will tell you which margin is involved. Okay. So what is there? What is seen over here? So this is a blood vessel wall, and what is present inside is a tumor. How do you know it is a tumor? Because you can see a lot of blue. Blue represents the nuclei. So how do you know this is viable tumor? How do you know this is necrosis? So in tumor again, you will see a lot of nuclei. Here there is no nuclei, so that means this part of the tumor has undergone necrosis. So here you can see perineural invasion. That is, a nerve is almost surrounded by adenocarcinoma. See, this is the tumor. Lot of blue, right? So it is surrounding the nerve. So what you see over here, this is nothing but nuclear pleomorphism, which is a characteristic feature of malignancy, right? And what you can see over here, this within the nucleus, these are prominent nucleoli. Okay, so this is a colonic biopsy from a tubular adenoma, which shows where there is low-grade dysplasia, which is seen, right? So you can see a dysplastic crypt. I'm reading it out. A non-dysplastic crypt is apparent at the lower right. So see, this is the dysplastic crypt, whereas these crypts are normal. Right? You can just see and you can make out the difference. So how do you know that this is dysplastic? How do you know these two are dysplastic? Where you see more blue, that means there is some amount of cell division going on over there. So that is so these two are dysplastic crypts. These two are dysplastic crypts, right? This is non-dysplastic. Now this is a well differentiated squamous cell carcinoma where you can see foci of keratinization, right? This it looks like nests of keratin. This bright pink that you can see, it is a nest of keratinization which is seen in squamous cell carcinoma. So these also are called pearls, that is pearl formation. So moving ahead, so this is a well differentiated adenocarcinoma. How do you know it is an adenocarcinoma? Because this structure that you can see over here, these are glandular structures. So how do you know it is a gland? Because so you have cells lining all across. Inside you have a blank space. That is typical of a gland. So what do we have here? So here when you see this tumor, you can actually see a lot of clear spaces in between, right? So these clear spaces in between, this is typical of a clear cell carcinoma. So this clear cytoplasm. So this is a metastatic clear cell carcinoma. So why are these cells clear? They are clear because there is a lot of presence of glycogen as well as lipids. So these cells, they are large, they are polygonal, they have clear cytoplasm, and the nuclei are usually placed centrally. So if you zoom in and see over here, you can see that these are neutrophils and they are multi-lobes. There are multiple lobes in this, right? So that means there's an acute inflammatory process and the neutrophils have infiltrated. So this is an slide of an eosinophilic esophagitis. This is eosinophilic esophagitis, right? How do you know it is eosinophilic esophagitis? Because there are a lot of eosinophils. How do you know it is eosinophil? You see, if you look at this carefully, you can see pink and you can see something which is brighter red, right? That bright red that you see is usually present in eosinophils. Again, in this tumor, see where there is no, see here you can see a lot of blue, right? Over here you can see so much of, blue in all these areas. This patch you can see no blue. That means this is a part of the tumor which has undergone necrosis. Okay. So what is this? So this, you can see some brown color seen over here. This brown color, whenever it is seen in a biopsy, it indicates that there is iron. And how do you stain that brown color? You stain that brown color using something called a pearl stain. So pearl stain is used to stain iron. Okay. Now you can, when you zoom in, you can see that these cells over here, let me outline one cell for you. This is one such cell. All right. See, this is again another cell. So when these cells are shaped like this, it is shaped like a spindle. These are spindle cell. These are spindle cells. Where are these spindle cells typically seen? They are typically seen in gist. Spindle cells are typically seen in gist. So here I've included a table which has some of the histochemical stains which are used for tumors. Please go through this. I'm not going through it because of, in the interest of time actually. Then here I've included an image which is of a Sanger sequencing. This name is not so important, but what is important is, what is important in this, apart from the name, is you can see there is some mutation which is happening over here. So how do you identify the mutation? So you can see there is green, there is green, there is green, there is green, right? Now there is a big green, but the green here is small, and you have a extra red. That extra red is representative of what is called a BRAF V600 mutation. So where is this BRAF mutation seen? It is seen in melanoma, colorectal cancers. It is seen in some thyroid cancers. Now, when you see a microscopic image which is like this is a image of an electron microscope. Now, this is a very interesting image. So here, this is an MRI image. How do you know it is an MRI image? Because you can't see the bright shining of the bone. And where the arrow is pointed, you can see it looks. See, it is a. See, it does not have a very. It has a clear edge, but it is not a smooth edge like this. It is something like this, right? And when you want to see within it, when you see within it, you can see it looks like whorls. No? See, this is one layer, one more layer over here. This is characteristic of a gauze piece being left in the abdomen. So a gauze piece looks like this, right? So when a gauze is left, when a gauze piece is left inside, what is it called? It is called a gauzy bioma. An easy way to remember it is, so suppose if you leave a gauze piece inside the abdomen when you are operating, people are going to gossip about you, right? That is why it is called a gauzy bioma. Okay, so what does this image show? So this is an ERCP. That much we've already established, we already know. Now you can also see there is contrast over here, there is the dye over present over here. So the gallbladder has been removed, obviously. That is why the gallbladder is not seen. You can see there's a gap over here. This gap is indicative of a bile duct injury. Okay. Now, let us look at the difference between how. So, see, this is the penis. This is the penis. This is the testis, epididymis. This green that you see, it is a peritoneal sac. Now, when the bowel is entering, that means it is an inguinal hernia, right? In a so that means in a inguinal hernia, the process of vaginis, that is the peritoneum, is quite patent. In a hydrocele, that is not the case. It is quite thin. So it is a thinly patent tract that allows the fluid to track in, and you'll get hydrocele. So this patient, this patient has a huge swelling in the on the left hand side. This could be a hydrocele, it could be a hernia. You have to examine it clinically to differentiate it. So how do you say it is hydrocele? In hydrocele, you will get getting out the swelling that is positive, and it is brilliantly transilluminant. So this is an intra-abdominal image, and what you see over here, this is a intra-abdominal testis. And this is present at the internal inguinal ring. So again, when you see these two round structures, this is the testis. So if you can see red and blue color over here, you can't see a red blue color, that means this is a Doppler image. Why do you see red and blue over here? Because here the vascularity is well maintained. Here there is no vascularity. Why is the vascularity not maintained over here? Probably because it has undergone torsion. So see, this is the an image of the testis. You can see over here how torted it is, right? But even though it has undergone torsion, the testis still looks healthy. So this patient has see, there is torsion. So this is the epididymis, this is the testis, this is the epididymis, and you can see something protruding out, right? What is protruding out is called a hydatid, or a it is also called a appendage of testis, right? Or it can be an appendage of the epididymis. What is black? That means this has undergone torsion completely. It is not viable. It has to be excised. This is a cause for pain. Okay. So what does this show? So this basically, what they are holding over here, you can see blood vessels, right? So that means this structure is vascular, and you can see the surgeon is holding it between his thumb and his forefinger. So this is a very small structure. So it is that of a child, and these blood vessels are typically present in a hollow viscus, right? And you can see that an opening has been made over here, and whatever is present beneath, you can see that, right? So this is a example of congenital hypertrophic pyloric stenosis, and a surgery has been done where a Ramsted pyloromyotomy has been done. So what is this? This is an intersusception. See, you can see that this portion, it as though it is going inside this, right? It seems to be entering into that. So it is an intersusception. So what do we see over here? So basically, actually, it's a very difficult image to identify. Even for me, it is difficult to identify. But see here, you can see this black thing, which looks like air, and here you can see a mass, right? So basically, air enema is being used to reduce the intersusception. So this is a Meckel's diverticulum. See, this is the bowel. This is the bowel wall. All right, this is the bowel, and this is the diverticulum. This is the Meckel's diverticulum, which is due to a persistent vitellointestinal duct. So this is a Meckel scan. So this is a Meckel scan, and what can you see? So you can see a black structure over here, and over here, right? So this is the stomach, obviously. This is the Meckel's diverticulum, and it is showing the same color as the stomach because the Meckel's diverticulum here, it contains gastric mucosa, and it is present over here. So this is the urinary bladder, where it is being, because it is being excreted by the kidneys. So now this is an example of a tracheoesophageal fistula. So here you can see in type A, the upper end and the lower end both are blind. In type B, the lower end is blind, but the upper end is connected into the trachea. Lower end, in type C, upper one is blind, but the lower end is connected to the trachea. Type D, both both upper and lower are draining into the trachea separately. In type E, it is like an H shape. So there is continuity between the esophagus and the stomach, but there is a fistula between that and the trachea. So this is a double bubble sign. So one bubble here, two bubbles here. This double bubble sign is usually seen in duodenal atresia, right? And in duodenal atresia, the incision that is used to repair it, it is called a diamond anastomosis. So see, this resembles that of this looks like a diamond, right? So that is why it is called a diamond anastomosis. So here in this patient, you can see that all this bowel is normal, but suddenly after that, the bowel has become very narrow. This can't be appendix, right? Because the appendix is not this long. So this is small bowel atresia. So here again there is some amount of, not some, there's a lot of gangrene of, or there's a lot of vascular compromise of the bowel, right? So this vascular compromise, it has happened because of small bowel volvulus, okay? And this is the head end of the baby, this is the tail end, and this is the leg end, right? What you can see over here, see if you zoom in, this is the appendix, this is the terminal ileum, right? So the terminal ileum, cecum and the appendix, they are well perfused. So that means there was some small bowel volvulus which affected majority of the small bowel. Now, this patient, you can see that this is the rectum, this is the sigmoid colon, all right. This is the descending colon, transverse colon, and ascending colon. But this, since it looks of a smaller diameter, this is microcolon. Microcolon is seen in meconium ileus. So moving ahead, in this patient, you can see a lot of air within the abdomen, right? So this is pneumatosis intestinalis. Here, this is so see, this is an example of a neonatal necrotizing enterocolitis. So in the previous image which I showed you, see, this is because of, see, this is dark in color, right? So that means there would have been some amount of venous congestion. That venous congestion would have been because of an obstruction in the blood supply or the venous drainage as well, right? So that is where the blood gets collected and there is congestion. So this appears maroon red. But here, if you see, it is black in color, right? So this is neonatal necrotizing enterocolitis. So this is a fulminant appearance. Now, this is the bladder, right? Urinary bladder, and this is the rectum. But you can see over, so below the bladder, you have the urethra, which is supposed to come like this, right? But if you see closely, there is some communication between the rectum and the urethra. So this is a rectourethral fistula. And what is this white dot? This white dot has been placed where the anal opening should have been. So this is a case of inorectal malformation. Now, this is a barium enema. It is when in an infant, which shows a transition zone. So, you can see a transition shown in the proximal sigmoid colon between the dilated proximal normally innervated bowel and the contracted aganglionic rectum. So, one moment. Array. So if you see, this is the sigmoid colon, all right. This portion over here, this is it is of a smaller size. It is contracted because it is aganglionic, and whatever is present proximal to it, this is the dilated proximal zone. So somewhere in between over here or over here, you will get the transition zone. So what do you see over here? So how do you identify this image? So firstly, you can see that this is you can see this is the penis and this is the abdomen. Something is coming out from center of the abdomen, right? And there is no membrane covering it. Whatever comes out of the umbilicus, it can either be a gastroschisis or it can be a omphalocele. Here there is no membrane covering it, so it is a gastroschisis. Whereas in an omphalocele or in an omphalocele, which is also known as exomphalos major, this is also known as omphalocele. You can see there is a membrane covering all the contents. So this is present in the lower back. This is a sacrococcygeal teratoma. So this is a image which shows that if you want to give fluids to a baby, where to a child especially, where there is no venous access available, you can insert an intraosseous needle, right? So this intraosseous needle, it is inserted 1 to 3 centimeters below the tibial tuberosity. So what is this? What does this image show? So see, in this image, you can see that these are the ribs, right? This is the lung. This is the lung. So on the left hand side where lung should have been, you can see the stomach. How do you know this is stomach? Because these are the gastric contents. This is some fluid and this is air, right? So basically the stomach has gone and occupied the position in the thorax. So it is traumatic diaphragmatic rupture. Along with that, if you look at the abdominal wall, you can see some soft tissue changes. So this is indicative of abdominal wall bruising, which further points to the presence of trauma. So here you can see a pinhole meatus. So this is phimosis, which could be due to balanitis xerotica obliterans. But this is a pinhole meatus seen in phimosis. Okay. So now this is the scrotum, right? This is the scrotum and this is the glans penis. Fine. And you have an opening which is present on the dorsal surface. So whenever there is a urethral opening in the dorsal surface, it is what is it called? It is called a epispadias. If it is on the undersurface or on the ventral surface, then that would be called a hypospadias, right? Okay. So what does this image show? So this is a retrograde pyelogram. All right. How do I know it is a retrograde pyelogram? So this is the ureter. It is actually a mega ureter, and this is the kidney, but the kidney also is bigger in size. So this is a hydronephrosis. Now you can see the dilated kidney, you can see the dilated ureter, but where is the bladder? You can't see the bladder, right? That means there is some obstruction over here. There is some obstruction at the ureterovesical junction. So this is an image of a voiding that is of a micturating or a voiding cystoureterogram, where you can see reflux present on the where you can see reflux. How do you know it is reflux? So as the patient is urinating, right, you can see some amount of dye, that is some amount of dye which is supposed to present in the bladder traveling up as well. So as it travels up, you know that there is some amount of reflux. Okay, what is this lateral view showing? Okay, so this child has posterior urethral valves. So see, this image will never be given to you in the exam, and you are asked to identify what it is, right? You will be given this image and some question. They might ask you some question from this image. So how do you identify this? So you can see that there is some amount of, this is some dye. Let me use a different color. There is some amount of dye over here, okay, which is coming, but suddenly it stops. So why does it stop? Because there is a posterior urethral valve. So there is a posterior valve present over here which impedes the obstruction. Because of the posterior urethral valve, the whatever is present proximal to it dilates, and you can see trabeculations of the urinary bladder. So it is not uniform. It is not like this. On the other hand, it is something like this. So there are trabeculations, right? So moving ahead, so in this image, you can see the urinary bladder, fine, and you can see something entering the urinary bladder, and there's a catheter. So whenever this is there, that means it is a mitrophenol stoma, and this that you see over here, this is the appendix. This is the appendix, and the patient is able to catheterize the urinary bladder via catheter, via the appendix, right? Now this urinary bladder is not, since you can see suture marks, it is not the natural bladder, it is a refashioned bladder, right? Okay, so what is this patient undergoing? So in this patient, you can see that she's on some sort of a gym cycle. So she's exercising, right? At the same time, she's breathing out. Okay, and there are a lot of monitor space. So there is something in her going in her chest, right? So that is going to take an ECG of hers, and whatever since she's breathing into a balloon, her respiration is also being monitored. So this image is asked you in the exam, and they ask you, what is this patient doing? So this patient is undergoing cardiopulmonary exercise testing. So what is this CPET? CPET is the gold standard measurement of a patient's fitness, right? In this, the oxygen consumption and the carbon dioxide production are measured while the patient undergoes vigorous exercise, which is increment in nature, for 10 minutes. So at the start of 10 minutes, it was the exercise of a slightly lower intensity, and as time progresses, the intensity of the exercise, it keeps increasing. So this is an anesthetic machine. How do you know it is an anesthetic machine? So you can see this is where the anesthetic gas comes with. So this is the desiccating agent. See, whenever the patient breathes, you can see this move up and down, right? Okay, so this is an example of an oropharyngeal airway, which is also called a Gedel's airway. This is called Gedel airway, right? This is a supraglottic airway. Whenever you see a tube like this with something which is broad, right? That is an example of a supraglottic airway. Now, this is a laryngoscope, right? Laryngoscope can have two sorts of blades. So, one is Macintosh blade is a curved blade, Miller blade is a straight blade. This, if you look closely, see, this is the tracheostomy blade, right? So, this is the Macintosh blade because it is curved. So, it is something to do with the airway, and you can see it is written over here, AirTrack. AirTrack, this is the brand. Now, AirTrack brand may not be present in the, it might not be given in the exam, but basically this is an intubating device. Now, this that you can see where you can see light glowing over here, and so you can see this long tube. This is a fiber optic intubating bronchoscope, right? So, it is the length of this tube is obviously smaller than that of a colonoscope. So, in this image, we can see a right tension pneumothorax. How do you know it is a tension pneumothorax? So there is it is more black over here, which indicates that there is presence of air, and this diaphragmatic lobe, it is slightly depressed. So there is some tension which is depressing it. Along with that, this, see, there is no heart shadow, it has been displaced to the left. So there is some amount of tension. That is why it is called so that is why it is a tension pneumothorax. So we'll take a break over here, and I will see you in a few minutes. So let's continue. So this is a CT scan. Again, because of the bone, you can see that it is CT scan, right? And you can see a very bright image, I mean, very bright shade over here. These are all blood vessels. And there is some contrast which has been given into that. Now, within this blood vessel, you can see a filling defect over here, right? This is a filling defect. So this is a pulmonary embolism, pulmonary artery embolism. So, what image is this? This is a fine bore feeding tube with its guide wire. This is the guide wire, whereas this is the feeding tube. This is PEG. I have discussed PEG previously also. So, see, this is the stomach. You can see an internal bumper and an external bumper, which is keeping it in place. So, this is again an image of PEG. Okay. So, in this patient, there is some amount of bruising in the over the mastoid process, right? In the post-auricular area. This is called battle sign, and it is seen in skull base fracture. So, here you can see that there is a fracture of the skull bone, right? And this has become depressed. So, it has gone in. So, there is a depressed fracture. See this bone was supposed to be like this, right? But you can see it is depressed. At the same time, you can see one more crack over here. This is undisplaced fracture. So here too you can see a fracture. When you do a reconstruction, you can see that there is something over here. So this is seen in extradural hematoma. This is that biconvex or the uh, lentiform shaped opacity, right? This patient, you can see there's some amount of midline shift which is happening. It is, see, this is more away from the midline than this. So this is a midline shift, and you can see an opacity over here as well. So that means there is some amount of hematoma, right? Here you can see a burr hole. A hole has been drilled in the bone, right, to evacuate the content. That is a burr hole. So now in this patient, you can see some amount of blood, but this blood, it is away from the skull. It is not attached to the skull. So this is an example of a subarachnoid hemorrhage. Here there is midline shift as well. Sorry, not subarachnoid. This is subdural hemorrhage. This is subdural hemorrhage because it is very close to the dura. In this patient, there is bilateral subdural hematoma. So you can see a hematoma over here, as well as you can see some bleeding present over here. See, this is the margin of the brain, right? You can see some blood collecting over there. That is why it is, and this blood is of varying densities. So that means this patient would have had multiple episodes of bleeding. This multiple episodes of bleeding which happens, right? It is more commonly seen in chronic subdural hematoma. Whereas in subarachnoid hematoma, I mean, you don't see a chronic picture. So here you can see an extradural hematoma, right? And here you can see again small islands of hematoma. Okay, so the most common cause of death in any trauma, the first most common cause is CNS, second most common cause is bleeding. This is not your level, let me skip this image. So this patient has undergone a gunshot wound. You can see these many types of this opaque things, right? So these are gunshot wounds. So you can see a gunshot fragment over here as well. So this is a liver, and you can see a crack in the liver, right? So the liver has burst basically, and the liver burst because of a compression injury to the liver. So what maneuver is being shown in this image? This is the Pringle maneuver. So whenever you do an open surgery, especially in the gallbladder, the incision, that is the Koch's incision, which is placed in the right subcostal region, it should be big enough to allow your complete hand to go in, because if there's a lot of bleeding that is happening, you can just put your hand in the hilum of the liver and you can compress those structures. That is called the Pringle maneuver, because it was, see, when you are blocking the, when you cause compression, you're blocking the entry of blood to the liver, right? Blood enters the liver from both the portal vein as well as the hepatic artery. So when you occlude that, there is no blood entering the liver, the liver cannot bleed. So this is a spinal log roll that is happening. This log roll happens because of spinal protection. As you can see, 1, 2, 3, 4, 5 people are required to do a spinal log roll. So this patient, you can see something like a headphone which is there, right? This headphone is used to maintain skeletal traction. This is called skull tongs. Now this is sites of the fracture of the mandible, right? So one, you have the neck of the condyle. This is the neck of the condyle. This is the most common site. Then you have the angle of the mandible, and then you have near the mental. This is the mental foramen. So it is near the mental foramen. So this patient, he has, if you look at the teeth, he's not able to open his jaw. So this is Rhizus sardonicus, right? Rhizus sardonicus means what? Sardonic means something which is mocking, right? So like somebody is mocking you, maybe with a smile like this on one side. That is, so this is Rhizus sardonicus, which is seen in lockjaw. This is an example of a pressure sore. I'm sorry, it is an example of a, see, pressure sore would have been present over here. So I made a mistake. Pressure sore would have been present over here, right? But this is an example of a necrotizing fasciitis. So why do you say necrotizing fasciitis again? Because see here, this has become necrosed, and around that you can see some more redness around it, some more inflammation around it. So the same image, I mean, this necrotizing fasciitis is the same patient which has progressed further on. Okay. So this is an image of gas gangrene. There is no way to tell that it is gas gangrene just by looking at it. But if there is subcutaneous crepitus present, then that would indicate the presence of gas gangrene. Okay, so now I've shown this image to you because of this concept of angiosome. It is because of the concept of angiosome that plastic surgery is possible. So basically, angiosome is nothing but a blood vessel which is supplying a particular portion of the skin and the muscles, right? The tissue, each block of tissue can consider this to be blocks of tissue which are supplied by its different angiosomes. What is communicating between these two angiosomes is what is called choke vessels. So you can see these vessels over here in between. These are called choke vessels, right? Now these choke vessels do not have any names, but the vessel which give rise to these choke vessels, they always are named. So this will be a named artery and a vein which then give rise to these choke vessels. So this is an example of this. This is a example of neurofibromatosis where you see multiple lesions, and these are all nodular or papillary lesion. This is neurofibromatosis. So this image, you can see that there is some hair. So this is the axilla, and you can see the sinuses present. This is an example of hidradenitis suppurativa. So this lesion is pyoderma gangrenosum, right? So where the subcutaneous fat has been infected, and so this is affecting the legs, whereas this is affecting the breasts. So this patient has got impetigo. How do you identify impetigo? You can see this crust present over here, right? This crust is typically honey colored. It is honey colored, which is why it is called impetigo. See, this patient, he's got erysipelas. So this is typical of erysipelas. This is cellulitis. So you can easily see the cellulitis over here. This patient has got necrotizing fasciitis of the orbit and the facial skin. So the eyes almost occluded because of the edema. This is acute infectious purpura fulminans caused by meningococcal septicemia, right? So what is important in this image is you can see very clear demarcation. So why is this demarcation present so nicely? What is the reason behind this demarcation? So see, note the sharply demarcated necrotic areas distal to the affected end or perforating arteries with surrounding normal skin, right? These are called miliary lesions. Many of you will have this on your face actually. So these are called where you see small, it looks like a white head, but it is actually a miliary lesion. So these are multiple sebaceous cysts present on the scrotum. So this is a junctional nevus, right? And this is a compound nevus. So now how do you differentiate between this junctional nevus and a compound nevus if given in the exam? So let us look at it one by one. So why is it called junction? Because it is present at the junction of the dermis and the epidermis, right? Compound because it is involving both the dermis as well as the, sorry, it is both a junctional nevus as well as a dermal nevus, right? So when you want to look at histology is not required. When you look at the clinical appearance, see a junctional nevus, it is flat or it is slightly raised, whereas a compound nevus is usually raised. So when you look at this nevus, it looks uh, flat to me. So let us look at this compound nevus. If you see carefully, it looks as though this part has been is slightly bulged. So it is slightly raised, right? Okay. A junctional nevus is uniform, it is of uniform color, right? Whereas a compound nevus, it has a variable color. So now let us look at the different colors. So this is the junctional nevus. See, this entire thing, it is uniformly colored, right? It is uniformly colored. There's a small island in between, but in the middle, but that is not of much significance. But by and large, the entire thing is uniformly colored. Now, if you look at a compound nevus, see, you can see different colors over here, right? The periphery is of a different color. Then there's a darker shade. Then there's one more shade where it appears to be raised, right? So, in a compound nevus, so the way to remember it is by the name. So since it is compound, it has compound shades, but junctional is uniform. Then a junctional nevus is typically smaller. This is typically bigger. Now looking at the borders. In nevus, the borders are almost always well defined, right? So, but in compound nevus, because it is a compound thing, sometimes it might be irregular. So let us look at this image. So this image, the margins are it is fairly regular, fairly well defined, right? Same thing over in the junctional nevus. So now what is this? If you zoom in closely, you can see that it is a raised lesion first of all. Secondly, you can see some hair which is coming out of, which is arising from it, right? So there's that small vellus hair. So this is basically a intradermal nevus. So intradermal nevus, it is raised or papular. It is soft to firm in consistency. It is usually of the same color as skin, but it can also be light brown or dark brown. The borders are well defined, can be dome shaped or pedunculate, it may be hairy. Now this is a Spitz nevus, right? Spitz nevus, it is different from both compound as well as junction nevus. The first difference that you can see is it is not that brown in color. It is more colored to like the skin, right? So it is typically pink or flesh colored, but it can be pigmented, right? It is firm or hard in consistency because it is raised. So it is firm or hard in consistency, and so it is dome shaped, that is, it is raised. Then it has well defined borders just like the other types of nevi. This is commonly present in the head and neck and in the legs. So this, it is easy to identify. You can see a nevus, you can see a nevus, and you can see a halo around it, right? That is why it is called a halo nevus. So now this is an example of a cafe au lait macules, right? So again, I'm very fond of saying that surgeons lead very boring lives. So this guy wanted to take his wife wanted to go abroad basically, but he had no time. So he told his wife, I will show you California and I will show you Italy in a patient only. So he brought this patient. I think probably his wife would have been very excited to see that in a patient. So he said that these are cafe au lait macules. See, these are calm macules. Calm macules are associated with neurofibromatosis, right? But if you see these two macules, one the border is, it is almost straight. So this is like the coast of California, whereas here the borders are kind of irregular. This irregular is like a border of Maine, right? So this is a cafe au lait spot, and there are two variants. One is the smooth coast of California border, and the other is the irregular coast of Maine border. Right now, why is this coast important, or is it not important? So it is important because this coast of California is associated with multiple syndromes, right? But this coast of Maine, it is not associated with syndromes. So if a patient comes to you and the patient is worried, looking at these cafe au lait macules, and the patient is worried whether they might have an underlying syndrome, the easiest way of distinguishing it is by looking at the borders. So coast of California, that is a smooth border, is more associated with syndromes, whereas the coast of the irregular border or coast of Maine is not. Then this is a nevus spilus. So nevus spilus, if you see closely, first it is present on the back. It is usually in the midline, and within the nevus you can see the small dots, right? So this is an example of a nevus spilus or a speckled nevus. So why is it called speckled? Speckled is, it refers to those small dots. So these spillus, so you can see it is dark brown, right? So it resembles a cafe au lait macule, but the difference is the cafe au lait macules, they are uniformly colored, whereas the nevus spillus, they will have hyperpigmented speckles, that is those dots throughout. That is the main difference. Now this is the image of a probably of a neonate or an infant, that is of a small child, and it has to be an infant only, because this Mongolian spot, that is, you can see this bluish or purple or violet, any some shade of blue. This discussion present on both the buttock regions and in the back. This is called a Mongolian spot. This is typically seen in neonates, and as the child grows, it usually disappears. I too have an, and my son had this Mongolian spot when he was born. It has decreased now. It is not completely disappeared, but it has decreased. So this is blue in color, right? So this is a blue nevus. Now you need to know the difference between two important conditions. One is the nevus of Ota and the other is the nevus of Ito. Now Ota and Ito, I do not know why they had to give similar names to make this so confusing and so irritating. But nevus of Ota is usually present on the face. So it is present in the distribution of the trigeminal nerve, more specifically in the first and the second division of the trigeminal nerve, right? Whereas the nevus of Ito, so this is Ota, because it is present on the face in the region of the trigeminal nerve distribution. But the nevus of Ito, it is usually present in other areas. So for example, it can be present in the shoulder region, thorax, anywhere else. Now, this Ota and Ito can coexist in the same patient, right? The same patient can have both Ota as well as Ito. So, I mean, you have to memorize this. I do not know any mnemonic actually which can make this simpler. I mean, the only thing that I can think of is, so let me make an attempt. See, A is the first letter of the alphabet, right? So Ota is going to be present in the first and second subdivision of the trigeminal nerve, right? Okay, so what is this called? This is a spot diagram. No need to go into details. It is present on the scalp, and this is known as the nevus sebaceous of Jadassohn. Jadassohn was probably the guy whom it is named after. So it is nevaceous. It looks at the same time, it looks like a sebaceous cyst, right? But it is of a way bigger size than a sebaceous cyst. So it is called a nevus sebaceous. So this is adenoma sebaceum. This is seen in tuberous sclerosis also, where it is called Bone-Wills disease. This is an example of a rhinophyma. So this is an extramammary patches disease which is involving the perineum. So this is the, you can see pubic hair over here. This is the perineum, and you can see these lesions over here. This is typical of extramammary Paget's disease. See, along with over here, you can also see it in the entire perineum, right? This is a giant congenital pigmented nevus. Looking at the image, you can judge that it is a small child and it is so big in size. That is why it is called a giant congenital pigmented nevus. Okay, now this is a dysplastic nevus, right? So what do you mean by dysplastic nevus? So in normally whatever nevus I have shown you so far, if you go back, scroll up and see the compound nevus and the junctional nevus, those are usually symmetrical, right? But a dysplastic nevus is asymmetrical. So what do you mean by asymmetrical? So if I were to take a scale and draw a line somewhere in between, if it were to be symmetrical, it would appear the same on both sides, right? But that is not the case. So see, even if I were to draw a line somewhere else as well, but in the middle, see, one side looks smaller, one side looks smaller, one side looks bigger. The same thing with this lesion as well. See, one side is small, this side is small, and this side is big. So it is asymmetrical. Along with it being asymmetrical, the borders are irregular. So what do you mean by these irregular borders? So see, for a nevus, if you look at any mole in your own body, you will notice that it is very uniformly bordered, right? It may be like this, but it is very uniformly bordered. So basically, sorry, not like this. It may be of this shape also, but you know where the nevus ends and where the normal skin begins. Whereas in dysplastic nevus, even if you zoom in and see, you are not sure as to the border. So it's see something like this, it's going over here, it's coming. So the borders are irregular. Then there's a lot of color variegation. So there are multiple colors. So you can see different shades present in this nevus. Then the diameter. So it is larger than an average mole. So if it is more than 5 millimeter, it is considered to be malignant, right? So this is nothing but A, B, C, D, E, where A is asymmetrical, B is border, C is color, D is diameter, and E is the edge. So this is another spot diagnosis. This is an example of a cutaneous horn. So this is also a spot diagnosis. This is called actinic keratosis. How do you identify this actinic keratosis? It is usually present on the scalp. So the patient is usually bald. It is present on the scalp and it is because of exposure of the sun. So when you see over here, you can see multiple lesions which are of different colors, right? And in some places you can also see flakiness. So this is an example of actinic keratosis or solar keratosis. It has two names. Now this is an example of a keratoacanthoma. So it looks like it is a raised lesion and it looks like there is a plug inside it. I mean, it looks like there is something which is filling this lesion. There is a plug which is filling that lesion. Now this is a Bowen's disease. It is which is nothing but squamous cell carcinoma in situ. It is a pre-malignant lesion. Now this Bowen's disease can be present anywhere or anywhere else in the body also. So if it is present in the shaft of the penis, it is called Bowen. But if it is present on the glans penis, it is called erythroplasia of Querart. So this is an image of erythroplasia of Querart where you can see the lesion on the glans penis. So this you can see, I mean, it is the lesion is evident just by looking at it. You can see this is a melanotic lesion, right? So it is and it is not raised. So it is a superficial spreading melanoma. This is also melanoma, but it is slightly raised. Raised, I mean that the vertical component of growth is more than the horizontal component of growth, right? So there are four types of melanoma. You have the superficial spreading type, you have the nodular melanoma, acral melanoma, and lentiginous malignomelanoma, right? So this is an example of the lentigo maligna melanoma. So lentigo maligna melanoma, you typically have you have a halo scene base. So it is basically a lentigene, that is, you see a brownish lesion within which you will see a blackish lesion. So this is an acral melanoma. Acral melanoma, as the name suggests, acral means it is present in the extremities, right? So this is present on the sole. This is an example of a subungual melanoma. Okay, and this, so here the nail is also involved. So this is a benign racial melanonychia. So moving ahead. So what is this? This is a pink colored lesion. So this is a salmon patch. This is a salmon patch. So a salmon patch. So when you would have read about hemangioma, you would have come across a few terms such as a hemangioma, then a salmon patch, and a port of wine stain. So that question that is typically asked is which one involutes and which one stays. So salmon is the name of a fish. Fish decay over time. So salmon patch, over time it fades on its own. Whereas if it is a port of wine stain, with age, with time, wine becomes stronger. So the port of wine stain, it becomes more and more stronger. The lesion becomes more and more stronger. This is a capillary hemangioma. So this is an example of a port of wine stain. Port of wine stain typically never crosses the midline. So even here you can see it is present on one side only. On the neck, face, as well as on the thorax, it typically does not cross the midline. So this, if you can see, so you can see one red lesion in the center, and you can see these legs coming out, right? As though it is a spider. So spider nevus, this is a spider nevus, and it is typically, it is a sign of, it is a marker of hepatic failure. Okay, this is a benign spot. It is called Campbell-De Morgan spot. So as you age, you tend to get a lot of these spots. Now this is a pyogenic granuloma. So these patients would have given you a history of trauma, and after trauma, the wound started to heal. That is, granulation tissue started forming, but there was exuberant granulation tissue formation, which is why it is called a pyogenic granuloma. The treatment for this is nothing but cautery. You excise it if required, and you cauterize its base. This is again another spot diagnosis. There is a glomus tumor. There is no need to go into details. It's a very interesting image. First glance, you might think it looks like a hemangioma, but this is angrier looking, right? That is because it has undergone malignant transformation. This is a angiosarcoma. This is an image of a Kaposi sarcoma, which is typically seen in HIV/AIDS patients. Okay, so what is the difference between a sinus and a fistula? So now this is a sinus and this is a fistula. So a fistula is typically a tract. So this is the tract. It is a tract which connects two epithelial line surfaces. So this is the skin, which is one epithelial line surface, and this is the second epithelial line surface. I think this is the this looks like the bowel, right? So it can be from colon, from the bowel to the skin, or from a blood vessel to the skin, or it can be from say from a duct, not blood vessel to the skin, because then that patient will bleed to death. Bowel to skin, or maybe duct to skin, right? And so basically, it is a fistula it is a tract which connects two epithelial lined surfaces. Sinus, on the other hand, it is a blind ending tract, right? Both sinus and fistula usually occur due to an underlying abscess or infection or injury. So now what do you see in this image? So this patient, it is obvious that he has undergone some burn, right? And if you look carefully, there is an incision which has been made throughout, almost throughout the entire axis of the patient's lower limb, extending onto the dorsum of the foot. If you look at the image of the thorax, you can see an image on the thorax as well as on the side of the thorax. You can see burnt tissue in between, right? So this is nothing but an escherotomy. This is an escherotomy. So whenever a burn happens, that tissue over there becomes hard and eschar is formed. So when you make an opening in the eschar, it is called an escharotomy. So why is this escharotomy necessary? Because since the eschar is very hard, it can cause pressure, it can cause it can occlude the underlying blood vessel. So because it can occlude the underlying blood vessel, the circulation can get affected. That is why it is necessary to make an opening along the eschar. So this, I think there was one more image of the same sort. So you can see one Z, one more Z. So this is a multiple Z plasty, and this Z plasty is typically done to for scar revision. So if you want to modify the appearance of a scar, you usually do this procedure called a Z plasty. So with this, we come to a conclusion of the session on images of today. So tomorrow I will be back. In the morning, I will discuss 3 question papers from INI-CET, and in the afternoon, I shall again be discussing a few images. Thank you.